Okay. A very good evening to one and all. Shri Ganpataya Namaha. ज्यांचे काने कुंडल मोती हार सगळ्यांना माझे आदरपूर्वक नमस्कार. आजच्या या इन्फर्टिलिटीच्या वेबिनारला जे की एबॉक्स इन्फर्टिलिटी कमिटी अँड पब्लिक अवेअरनेस कमिटीने जॉईंटली ऑर्गनाइज केलं आहे, मी आपल्या सर्वांचे मनापासून स्वागत करते. So let us have the inauguration, e-inauguration. Next slide, please.
Pratibha, can you unmute, please?
I now call upon Dr. Kalyan Baramde sir, whom we all very well know. He is the secretary of IAG. He is currently the chairperson of Infertility Committee AMOGS, an executive member of MSR. He has been the chairperson of Public Awareness Committee for FOGSI year 2019-22, convener for Mission Save the Uterus, which is still continuing, and past president of Latur OBGY Society. And he was also the organizing chairperson for AMOGS 2022 at Aurangabad, which we saw and how hardly he has worked for the same. And he has been working hardly to raise the levels of the organization. I invite Dr. Kalyan Baramde sir to take over.
Thank you, Dr. Pratibha madam, for this kind introduction. I welcome all in this AMOGS Infertility Committee, Public Awareness Committee of AMOGS, in association with Maharashtra ISAR chapter. I am happy that with AMOGS, MSR has joined hands, and I thank Dr. Prakash Trivedi sir, who is chairperson of MSR, Dr. Sadhna Patwardhan, who is secretary of MSR, and my dear friend, Dr. Chaitanya Shembekar, as a librarian of MSR. When me and Dr. Chaitanya thought about initiating this, we started from Nagpur and we are moving towards the central part of India, that central part of Maharashtra, that is Solapur Latur zone. So I invite everybody for this A to Z in obstetrics and gynec and infertility webinar. And I invite Dr. Pardesi sir and Dr. Sujata Dalvi madam. So Dr. Sujata Dalvi madam is the secretary of AMOGS. Dr. Pardesi sir is the president of AMOGS. So I invite Dr. Monica for introduction.
Thank you, sir, for the opportunity. I would like to highlight the fact that we are moving from communicable to non-communicable diseases, and infertility would be the major chunk of the non-communicable diseases that we will be dealing henceforth in the later years in the OBGY practice. I am also thankful for AMOGS Infertility Committee and MSR to team up with AMOGS TAC and Pardesi sir for allowing us to conduct this webinar under the AMOGS banner. I would take privilege to introduce Sujata ma'am first because she's there. Pardesi sir will join in a few minutes. Sir. Ma'am is a consultant obstetrician and gynecologist in various hospitals in Mumbai. She's an honorary clinical associate at Nauroji Wadia. She is currently the secretary AMOGS and the joint associate editor of Jogi. We welcome you, ma'am.
Okay. Thank you, Monica. Yeah, for such kind introduction. At an outset, as a secretary of AMOGS, I would like to express gratitude to AMOGS, especially headed by our president, Dr. Rajendra Singh Pardesi, for always encouraging some sort of a scientific session. Today's scientific session is by AMOGS Infertility Committee, chairperson being Dr. Kalyan Baramde, along with AMOGS Public Awareness Committee, chairperson being Dr. Monica Umbardar, and along with MSR, that's a Maharashtra chapter of ISAR, headed by our librarian, Dr. Chaitanya Shembekar. Today's topics are all infertility related, but they are of so much utmost importance that all those who have logged in will learn a lot from attending today's seminar, and they'll be able to put in their private practice. I wish all of them best wishes and good luck for their future endeavor. Thank you so much, Monica.
Thank you, ma'am.
Thank you, ma'am. Thank you for your blessing.
Thank you for the blessing. Now I invite Dr. Pardesi sir.
Sir has joined, sir. Yes.
Yeah, he has just joined. The Pardesi sir doesn't require any introduction across Maharashtra and now Foxy India also. He has presented 27 papers and out of it 20 national and 7 international papers. He's 6-time Best Paper Award in Foxy's ASCOG conferences.
It's okay, Kalyan.
Yes, sir. Yes, sir. Just finished.
It's okay.
Was faculty in many international conferences and was chairperson of FDA committee, awarded Dr. Hansotia Best Committee Award, VP of Foxy 2019 to 20, and now President of AMOGS 2024. Welcome, sir.
Good evening, everybody. Respected Dr. Sujata Darvi, our ever active Secretary of AMOGS, Dr. Prakash Trivedi, Dr. Sadhna Patwardhan, Dr. Lakshmi Srikhande, Dr. Ashok Kumar. First, I wish to congratulate Dr. Kalyan Baramde, Dr. Monica, Dr. Chaitanya Shembekar, our ever active chairpersons of AMOGS, and along with office bearers of ISAR and ISAR. This is the really nice CME, that, including topics of obgyny and infertility, having stalwarts like Sneha Bhoyar, Sunita Tanwarkar, Meghna Kamlapurkar, Meena Chidgupkar, and Rajiv Dabre. I wish every success to this webinar. I wish every success to Dr. Sneha Bhoyar and Dr. Sunita Tanwarkar for their future endeavor in Foxy. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir, for the words of blessing to all AMOGsian. You are a father figure in AMOGS and you always motivate youngsters like us to come into AMOGS and Foxy. Thank you for all the blessings, sir. Monica.
I would now take a privilege to introduce Chaitanya Shembekar sir and on behalf of MSR and invite him for his blessings.
Good evening, everyone.
Dr. Chaitanya is past president of Nagpur and he has a lot of work in infertility. He has memorable AMOGS infertility chairperson and now he's a librarian of MSR. Welcome, Dr. Chaitanya.
Thank you, Kalyan. Good evening, everyone. Respected Dr. Pardesi sir, Sujata madam, and my dear friend Kalyan, Sunita madam, and all the respected faculties and delegates. I welcome you all for this webinar on infertility. Actually, this is the brainchild of my dear friend Kalyan. मी त्याला फक्त बाहेरून पाठिंबा देतो आहे, मी मम म्हणतो आहे, but then it is all the hard work of Kalyan. Yes, it is the hard work of Kalyan, and I'm so happy that this webinar is spreading awareness and knowledge amongst the gynecologists on infertility. And I wish best luck to Kalyan, who is contesting for the Maharashtra ISAR elections, and last date is just 2 days are left, so please vote Kalyan if you have not voted yet. Dr. Sneha Bhoyar is also contesting for the post of Vice President, and our star, Dr. Sunita Madam, is already with us, and she is for President Foxy, and our best wishes are always with us, always and by always we are with you, Madam. So we have 3 stars for this CME. So please keep in mind Kalyan for MSR, Sneha Madam for Foxy Vice President, and Sunita Madam for Foxy President. Thank you very much for giving me this opportunity. Thank you so much. Thank you.
Thank you, Chaitanya sir. I would now request Dr. Pratibha to please take over the session and introduce our speakers for today, Dr. Sneha Bhoyar Madam.
Our first speaker for today is none other than Dr. Sneha Bhoyar, who is very knowledgeable and will enlighten us on evaluation of an infertile couple. Sneha Bhoyar Madam needs no introduction. She has received many awards and accolades, the most important being the National Individual Award Foxy in 2008 for outstanding work in rural obstetrics, Dr. Anandibai Joshi Award in 2005, Foxy President Appreciation Award in 2018, International MS Signature Award in 2020, and many Lokmat and various other UNICEF awards. She has given many talks and publications And she has done research as a primary investigator in fighting against cervical cancer, coordinator for Ankur project, and research on menopause, research on cervical cancer. Over to you, madam.
Thank you so much, Dr. Pratibha, for that kind introduction. A very good evening to all the stalwarts, respected Dr. Pardesi sir, Sujata ma'am, Dr. Sunita Tandulwadkar, the stalwarts of ISAR and ISAR, Dr. Prakash Trivedi, and of course, dear friends, Dr. Chaitanya Kalyan, Dr. Davade, and all the faculties and esteemed chairpersons. A very good evening to all of you. Thank you so much for the invitation and involving me as a part of this program. Just hurriedly, I have selected this topic, a very simple, basic topic. I just didn't want to miss this opportunity to with you all stalwarts. So I hope my slides are visible.
Very much.
Yes.
So,
Yes.
Yes. So, a very simple and basic topic, what a general gynecologist obstetrician should know about infertility evaluation. So, coming to the basic definition, failure to conceive after 1 year of unprotected regular intercourse. Of course, we need to specify here a regular intercourse because sometimes because of the occasional intercourse, the couple staying at distant places, maybe the fertile period is missed and the incidence being almost 10 to 15%. Now, what is the need for evaluation of infertility? The diagnostic evaluation of infertility is indicated for women who fail to achieve a successful pregnancy after 12 months or more of regular unprotected intercourse. And since approximately 85% of these couples may be expected to achieve pregnancy within that particular interval without any medical assistance evaluation, it as may be indicated for as many as 15% of this couple. If you have a look at this figure, almost 50% of these cases are because of the tubal factor, unexplained infertility, endometriosis, and other causes, whereas male factor contributes to almost 25% and ovulatory dysfunction contributes to 27%. So naturally, it's not only evaluation of these couples, but it is the basic investigations, counseling on the part of the patient as such, or maybe the family, which needs to be involved sometimes. And of course, the patient counseling is the most important, maybe I think the most neglected part many a times. At least 20 to 30 minutes of counseling is needed to put this patient on the right track. And of course, for the long-term compliance of these patients, which is a key to success of management. Both the husband and wife may need to be introduced or integrated either separately, but a combined counseling session should be conducted before going for the diagnosis as well as management. The patient counseling should be a combination of reality, honesty, and positive. Reality, we have to actually, even though the patients are non-medical, they may not understand the medical jargons if we use. Maybe we have to go to their level and explain them what is the roadmap of getting pregnancy. Natural intercourse for 1 year, investigations, treating the basic cause of their problem, almost maybe if with basic treatment, if they don't conceive, maybe need for IUI, 4 to 6 cycles, and if everything fails, go for IVF or even we have to be honest enough to tell them the fact that most of these couples see empathetically that maybe if there is a problem, you may have certain complex problems which need to be investigated further. We have to tell them that yes, you are going on a right track and maybe you can make it sooner or later. But if you fail, you have to go for further investigations and management. You may have to face these questions. Doctor, if everything is going on well, you are prescribing medicines and she is also taking it. Why is she that she's not conceiving? medications alone. So if she's not ovulating even with the highest dosage of gonadotropins, maybe she has landed up into premature ovarian failure, maybe she has a bilateral double block, husband may have azoospermia or severe oligostenospermia. There can be unexplained infertility, everything being normal. She just can be the indications for IVF. Failed 6 IUI cycles, bilateral tubal blockage, which could not be corrected even surgically, unexplained infertility, and when all other measures have failed, of course, when you plan for surrogacy, you have to go for IVF. You have to answer to whatever queries the patients come to you with. No question is stupid. Answering the queries improves the trust. It builds a long-term relationship with the patient as well. So what are the frequently asked questions? What is the fertile period? The period during which if you have sex, you can become pregnant. That is the simple answer. And it's around the time of ovulation, that is around 14th day. What is the correct position? Many patients ask you these questions. Any position where the penetration happens and ejaculation takes place is the correct position. Is daily sex required? Sperm remains alive for 48 to 72 hours. All of us know suffice. Now coming to the evaluation of the infertile couple proper. History and physical examination, very, very important. History, right from the menstrual history, obstetric history, history of any medications, family history of premature ovarian failure, premature menopause, history of previous MTP, spontaneous abortions, any surgical intervention, and history of infections can lead to all these problems. Physical examination may be general and systemic. Test for ovulation, assessment of ovarian cervical mucus interaction, detection of uterine Monica, hello.
Yes, ma'am. Hi, ma'am. You're audible.
Hello.
Hello.
Hello. Yes, Monica, could you hear me?
Ma'am, you're audible.
You're audible now. Yes. Neha madam, you're audible now.
Whether I got disconnected right now? Yeah.
Yes, ma'am.
Yes. Thank you so much. So I hope this is the slide you could hear. The relevant history as far as the menstrual history and the duration of infertility and the results of previous evaluation, the obstetric history and contraception use, if any, coital act, frequency, presence of vaginismus dyspareunia, past history, serious illnesses and various types of infections, PIDs, STIs, thyroid dysfunction, galactorrhea, hirsutism, maybe family history of congenital malformation, mental retardation, early menopause, and reproductive failures. Coming to the examination, general examination, the weight has got a lot of significance. BMI and, of course, the thyroid dysfunctions definitely can be diagnosed on general examination. Breast secretion, signs of androgen excess. Post speculum examination, very, very important, though nowadays because of the gazettes, people are not preferring to go for internal examination, gives you a lot of information. Per vaginal examination, uterine position, shape and size, mobility, tenderness, adnexal masses, dissection. Now, what are the indicators of ovulation? The menstrual history, the basal body temperature, serial follicular study, which you can do. You can get the exact information about the follicular size and growth serially by transverse sonography, serum progesterone levels, urinary LH. Of course, the male factor has areas can be used for clinical practice. Normal semen parameters, as you can see here, volume of more than 1.5 ml per concentration of 50 million per ml, motility of more than 40%, viscosity, that is liquefaction within 30 to 60 minutes, at least 4% of the normal morphology of the sperm, pH of 7.2 to 7.8, and leukocyte density of less than 1 million per ml. Cervical factor, even though it's a rare practice nowadays, abnormalities of cervical mucus production, evidence of cervicitis, and which could be judged what we used to do routinely previously postcoital test. There has to be abstinence of 48 hours, and of course, the test is done within 10 hours of intercourse. Presence of 10 or more motile sperm per field is suggestive of a good cervical mucus or good cervical mucus sperm interaction. Coming to the hormonal form of serum FSH, LH, estradiol, T3, T4, TSH, serum prolactin, and AMH gives you adequate information. Assessment of ovarian reserve. Of course, antral follicle count and AMH gives you ample information. Diminished ovarian reserve describes women of reproductive age group having regular menses whose response to ovarian stimulation is reduced to its normal counterpart. Now, what are the indicators or other predictors of diminished ovarian reserve? Women above 35 years, family history of early menopause, history of oophorectomy, radiation, chemotherapy, unexplained infertility, poor response to gonadotropin stimulation. However, poor results with any of these tests do not necessarily imply inability to conceive. So what are the tests for ovarian reserve? We have already talked about this. Day 3 FSH estradiol, and of course the clomiphene citrate challenge test. Early follicular phase intrafollicular count should be more than 3 to 10 in number, measuring almost 2 to 10 mm. And AMH, as we always talk about the combined AMH and intrafollicular count. Ultrasonography for the uterine abnormalities. To evaluate uterus, we have various kinds of ultrasonography, sonohystrography or saline infusion sonography, MRI, and hysteroscopy. For tubal patency and peritoneal factor. Here, I would just say that it's not only the patency, but the integrity of the function, both we have to evaluate. HSG, saline infusion sonography, laparohysteroscopy, and fluoroscopy, maybe even the hysteroscopic selective tubal cannulation. So the compromised tubal damage can occur after external or internal injury, inhibiting the normal transport of the gametes. So just evaluating or establishing patency alone doesn't hold that the tubes are good functioning as well. The overall prognosis of fertility depends principally on the insult and the severity of the tissue damage. Hence, assessment of the tissue damage, tubal damage plays a major role in predicting occurrence of pregnancy and the likelihood of developing ectopic pregnancy. The functional competence of the fallopian tube implies both the patency as well as integrity of the mucosal lining or the endosalpinx. So, coming to, I would just go ahead with this quickly because I think Madam Sunita Tandurkar is going to speak about ovulation induction and other topic as well will be covered. Just to go quickly, the various kinds of gonadotropin available. First generation derived from human postmenopausal urine. Second generation made by purification of natural human menopausal gonadotropin, and third generation, that is the recombinant FSH. The changes, how it has occurred, 80 to 90 it was HMG, 90 to 95 it was FSH, and 95 to 2000 FSH highly purified, and 2000 onwards still that it is the recombinant FSH nowadays. What it contains, I think majority of you know about this. Just to go ahead with the ovarian stimulation protocols, in short, what is the pituitary down regulation? This will be covered very well, so I'll just skip these few slides. And of course, the gonadotropin and the antagonist protocol. So for the general gynecologist, just to have few introductory slides, how you give the medications for ovulation induction, the oral ovulogents and the injectable ones in that gonadotropins and gonadotropin-DNRH analogs and antagonists. And then, of course, the follicular monitoring, which we do it by transvaginal sonography, and the finding a follicle, going for ovum pickup, of course, the preparation of sperm by the swim-up method, density gradient. Whole idea is to get the grade 3, grade 4 motile sperms without pus cells, debris, and epithelial cells and bacteria. So what is this IVF? There are 4 different types of IVF. Plain simple IVF, ICSI, intracytoplasmic sperm injection, MC, ICSI, and laser assisted hatching. Then, of course, with all these procedure, you come to IVF and embryo transfer, as it is done from day 2 to 6. But in most of the cases, the embryo transfer occurs between 2 to 3 days after egg retrieval, and after this stage, the embryos are 8 stages. 2 to 3 embryos suspended in the fertilization media are transferred to uterus. Nowadays, it is only 2 embryos, and maybe the recent trend is of single embryo transfer. So with this, I think I will just end my topic, which is just an introductory talk, and I'm going to listen to the other speakers for the details of this. Thank you, organizers, once again for giving me this opportunity. And with folded hands, I humbly request your wholehearted support for my candidature as Vice President Foxy for the upcoming elections. I have served Foxy and AMOGS in various capacities and wish to serve further with your support. Thank you so much once again, especially Dr. Kalyan, Monica, Chaitanya, and all of you. Over to you, Dr. Monica, once again.
Thank you, ma'am. Thank you so much for your presentation. It was an extremely good outline of the next few lectures that we will be listening to. Pratibha, over to you to introduce Sunita, ma'am.
Thank you, Dr. Sneha, madam. I thought you are a really infertility specialist than a OBGYN consultant. It gave us inputs about how to evaluate the patient of infertility, how to go about the treatment options.
Thank you so much. Thank you, Kalyan.
There is one question for you. Things on which IUI success depends. So that question will be taken by Dr. Tandurkar, madam, and will be covered in the next topic. Thank you so much.
Thank you,
Kasturkar, madam. Your question will be answered by Dr. Tandurkar, madam.
Okay, we have the next speaker for today, who is none other than our most lovable Dr. Smita Tandurkar, madam, who will be speaking on ovulation induction in IUI. She heads the Department of OBGY and IVF Endoscopic Center at Ruby Hall Clinic, Pune. She is an advisor and consultant at Dr. D.Y. Patil IVF and Endoscopy Center. She is a founder and medical director of Solo Clinic IVF and also a stem cell research center, that is Solo Stem Cells at Pune. Her extraordinary achievement is India's first stem cell baby and world's first at the age of 45 on 16th April 2018. We know her very well. She has achieved many awards, that is Icon of the Year 2022, Endoscopic Times, Pride of Foxy, Bharat Gaurav Puruskar, Best.
Can we move on?
Yes, ma'am.
Let's go to the academic part. Allow me to share my screen. Thank you, dear. Thank you so much for your kind introduction. Kalyan and Monica and Chaitanya. It's so pleasure. See, since morning, this must be my third webinar, and I have my Pravaha at 8 p.m. But when you come to Maharashtra, you have a different feeling. Ghari alyasarkha vaatta. And with Kalyan, Monica, and Chaitanya organizing, Kalyan MSR, if tomorrow you contest for a chairperson, directly you will win the elections. You don't need anything. We are looking forward to your IAG presidency before MSR chairperson post. And Sneha, wonderful to see you. I was very happy to see Raju. Raju is my classmate, friends for last 30 years, and feel like meeting old friends after a long. So let's start with, this is a very extensive topic, ovulation induction, or I can finish in 5 minutes. I'll try and make it a little bit more elaborative, explaining which drugs and when. Sister, can you close my door, please? So thank you for having me. Now, if we see the ovulation induction, which are the patients we think of doing wherever we do the IUI. Natural cycle IUI, we know that the success is so low that we always will stimulate, or whenever we want to give a time relationship to the patient. So PCOS, unexplained endometriosis, and the male subfertility. Usually everyone gives with their experience, with their evidence, or the way patient is presenting, we decide our stimulation protocol. But what should be our basic goal? Induce monofollicular growth. It should be least invasive, simplest, cheapest treatment option, giving us the best result, maximize the rate of singleton pregnancy, and minimize the risk of OHSS. Someone has to mute themselves. Before starting the ovarian stimulation, first important thing is we have to analyze the ovarian reserve, and then accordingly you select the correct stimulation protocol depending upon whether it is for a IUI or a IVF. Now, usually our protocol, the basic 4 things which we see is the age of the patient, her FSH, which hardly I do nowadays, MHAFC, and third most important thing is her response in a previous cycle if she has undergone stimulation towards you. Now, I want to make one concept clear to everyone. There are thinking when to start the gonadotropin or when to start the stimulation. For oral ovulogen, you can start on day 2, day 3, day 5, makes no difference. The clinical pregnancy rate, implantation rate is the same. Now, when do I add the gonadotropin? People have a confusion. First, I want to say, whenever you add the gonadotropin, always add on with the oral ovulogen. In Western countries, many times they give only gonadotropin. It becomes a little expensive cycle. It's nice to have an endogenous gonadotropin, that is endogenous FSH coming in with oral ovulogen and then super topping it with the gonadotropin. The problem arises when whether I should start gonadotropin on day 2, I should start on day 4, I should start on day 6. What protocol? So I'm just drawn a beautiful diagram for all of you. We all know that at the start of the menstruation or even before the menses start, the follicular recruitment starts. And by day 5, day 6, one of the follicle becomes dominant. Understand this concept very clearly. This follicle becomes dominant because it outgrows over the rest. Now, with the increasing E2 in the dominant follicle, the FSH decreases. The decreased FSH is not sufficient for the rest of the follicle, so they undergo atresia. While for the dominant follicle, because there is increased neovasculature, increase in the receptors of a FSH, there is a selective deposition of the FSH to this dominant follicle, and that is why even if it is a decreasing FSH, it is sufficient for a dominant follicle. Now, if my aim of the stimulation is to develop this follicle further, my aim of adding the gonadotropin is to make this dominant follicle little better, improve the follicular phase, then naturally I will add on day 6 onward, because by that time the other follicle undergoes atresia. Atresia means they are hyperandrogenic and they will not have the capacity to grow further. Now, if I want to rescue 2 or 3 follicles, naturally, I need to give a gonadotropin before they undergo atresia. So I'll start on day 3, day 4. So once my concept is clear, whether with the gonadotropin, I want only sustaining, that is, I'm giving for an unexplained infertility or a mild endometriosis, Or I want to have, instead of 1 follicle, 2-3 follicle, I will add on gonadotrophin earlier. So if I want to rescue one of them, I will be adding gonadotrophin and I will rescue 1-2 follicles more. Now, if this gonadotrophin dose is a small dose, it will rescue only 1-2 follicles. If you give a higher dose, it will rescue more follicles. And that's the difference we play between IUA and ART, the dose and the duration. Now, once you start the gonadotrophin, you just can't give 1 injection or 2 injection. You have to give till the follicle becomes dominant follicle, till your SCG is given. Once this concept is clear, this is again the threshold concept. I'm not going to go to this slide. It's highly complicated. What is important is all the follicles are undergoing atresia. You stimulate, you get out 1. You stimulate with the little higher dose, or your FSH is above the threshold you have given. So this is FSH I've given above the threshold level. I'll rescue 2-3 follicles is the same way I'm defining. Now, which are the drugs I can use? Clomiphene, age-old, letrozole, ancestral, tamoxifen. Believe me, when letrozole was banned for nearly 12 to 15 months, instead of clomiphene, I had moved on to tamoxifen, and it gives an excellent lining, because with clomiphene, the lining is always a problem. Then you have a gonadotrophins, and then you have here on this agonist or antagonist. Now, what is the prerequisite for ovulation induction? It's a mandatory to do day 2, day 3 scan. You cannot start even the letrozole 5 milligram, 1 tablet without doing a sonography. You have to understand that there is no remnant follicle of a previous cycle, or there is no cyst, and the endometrial thickness is 6. People ask me, do you do the hormones? I don't need to do E2, LH, progesterone. If the ovaries are small, the ovaries have the follicles of 4 millimeter, 5 millimeter, from where the estrogen will come. Definitely the LH will be less than 2 and the progesterone will be less than 0.5. I need to do only sonography. And if I see the cyst, second diagram, if I see the cyst, then either I will give her OC pill without doing any hormone pills and ask her to come next time. Or if I feel that this was the cyst which was persistent last time, it may be a simple cyst adenoma, it is not functioning, then to counter check, I may do LHE2 just to rule out it is a functional cyst or not. Now, selection of a dominant follicle occurs in an early follicular phase. So you can start on day 3 and tailor to each. Antiestrogens, clomiphene citrate and tamoxifen. Aromatase inhibitors, letrozole. I'm not going to discuss much about their mechanism of action. Just in one line about clomiphene, you can start on day 2, day 3, day 4, day 5. No problem. On spontaneous or menstrual, and you give it for 5 days. Pregnancy rates are similar. Usually the starting dose is 50 milligram. Maximum you can give 150 milligram. Friends, you know what I have seen, like legends of the country. Dr. Sadhana Desai, she has used clomiphene left and right for decades. And I have heard her sometimes in one of the conferences that she still loves clomiphene. While we probably have more used for 2 decades plus letrozole, and we love letrozole because we are not happy with the thin endometrium. Now, doses all depends upon the body weight, age, indication for the use, whether you want single or double or 3 follicles, and the past stimulation. Dose cannot be accurately predicted in very first cycle. Empirical increment titration is possible, and you can discontinue when 6 ovulatory cycle fail to yield a pregnancy. I never go. I'm showing you what the evidence is telling you, not what my practice is. But 6 ovulatory cycle fail. I never give more than 3 cycles of letrozole. Even in the young patient, if I have closely monitored, and if she has ovulated once on this side, once on this side, I like to add on gonadotrophins, or I will go for a further treatment. When to stop? When no ovulation. So in 6 cycles ovulatory, it is clomiphene failure, or this is a clomiphene resistance when no ovulation, or look at the endometrium, such a thin endometrium. But whenever you want to stop CC and you want to change to letrozole, please give 2 months break. CC has a longer half-life. So this anti-estrogenic effect will remain in the system. And even with the letrozole, you may not get good lining. So you should wait for 2 months. Now, these are the various causes of CC failure. I'm not going to go in detail of this slide because it's impossible to cover. But improvement of the result, one can think about if it is a PCOS, obese PCOS, weight loss, or insulin-lowering medication. Metformin is my favorite drug. I use in all obese PCOS. I continue that into the pregnancy up to 34 to 36 weeks, which latest guidelines some other time we will talk about it. Now, if she fails to conceive after 6 cycles of ovulatory, you expand your diagnostic evaluation or you change treatment strategy. That is, you add on gonadotropins. So there may be a coronal block, there may be a mild endometriosis you need to work out on. Management of CC failures, extended clomiphene, add on gonadotropins. Alternative may shift to or other oral ovulations. Now, do I skip CC completely? BMI higher patient, elderly patient, AMH more than 10, because these are the patients where I don't get their ovulation. I cannot say that because evidence doesn't say that hyperandrogenic patient you should not be given, though we know that it will not respond very well. What about the aromatase inhibitors? Yes. Aromatase inhibitors, I'm not going to talk about their mechanism of action, but higher rate of success with letrozole than with any other. Mechanism of action, it works on a hypothalamic level. It works locally in the ovary. Androgen augment the follicular FSH receptor expression, amplifying the FSH effect. This is very important. And it also induces within the follicles the high IGF-1 concentration, which synergizes with the FSH. So letrozole obviously becomes more synergistic. No anti-estrogenic effect, and that's why it's so many other advantages. You can start 5 milligram for 5 days. I usually don't start with 2.5 milligram. 5 milligram is my basic dose I start. But nowadays, I'm giving extended day 7, day 10, up to day 10. So on the 5th day, I start on 3rd day and I call the patient on 8th day and I check. If the follicles are like 12 mm, 13 mm, I tell them continue for another 2-3 days. There's no harm. And then you call them after 2-3 days. If the follicles have gone by 15 mm and so, then I may not give anything more. Cochrane also says that the letrozole, see with the letrozole, first is it has proved that it is not inferior to clomiphene. Then it has proved that it appears to improve the live birth rate and pregnancy rate in all compared to CC. And there is no difference in effectiveness between the laparoscopic ovarian drilling and letrozole. This is very important. So if you are not suspecting any pathology or your AMH in spite of a PCOS, AMH is like 4, 5, I may not think about laparoscopic ovarian drilling because in 2 years, the patients can become a poor responders or poor ovarian reserve. So I may think about letrozole because letrozole is much superior to any other. Pregnancy rate, the miscarriage rate, and all are same. I don't have to say about. Again, Cochrane in 2018 has said that letrozole improves the live birth rate, and this one, high quality evidence that OHSS rates are same. Multiple pregnancy rate is not much. This is a very interesting article. Why I have taken it? Because 14,500 cycles with 8,000 couple. This is a Chinese group who has compared natural cycle IUI versus CC IUI, letrozole IUI, and gonadotropin. Because of its quantity, the volume, I thought of going through the study. And what they have said is live birth rate, natural cycle IUI only 6%, while letrozole, clomiphene, and gonadotropins, all three are same. Multiple pregnancy rate, letrozole was the lowest, 1.3%, while cumulative pregnancy rate, if you see, around 25% in all, including gonadotropin cycle. And they said that letrozole is as effective with lowering the multiple pregnancy rate. Contraindication. It's very important. You should know contraindication of all antiestrogens and the aromatase inhibitors, liver diseases, kidney diseases, of course, HPO axis, any disturbances, pregnancy, and abnormal bleeding. What about the gonadotrophin? The Cochrane says that, yes, when you use with oral ovulagens, it will improve your clinical pregnancy and ovulation rate. But whether it will be transmitted to live birth rate, not sure. But when you use gonadotrophins along with the injectables with gonadotrophins, definitely your live birth also increases. Many a times we are happy with the success of the even oral ovulation. Unfortunately, pregnancy did not continue, but still I use it. At least I got that the implantation is not a problem in that lady. That itself is a great relief for all of us. What does the Cochrane says about gonadotrophin? Let's talk about gonadotrophins first. One, indication on all resistant drug or failure or persistent hypersecretion of LH in IUI cycles. Now, HMG and FSH, these are the two drugs one can think about using it. What does the evidence says? Cochrane from 2001 till today, recombinant FSH and urinary derived gonadotrophins are equally effective in PCOS patient. I did not put up the slide for unexplained to cut short, but friends, in unexplained, the evidence says recombinant is superior. While in PCOS, recombinant versus and urinary, both are equal. What is the advantage of recombinant with urinary then? Why some people use, or sometimes even I use? One, very low dose titration. I want to give just 37.5. I don't want to give too much. She already with letrozole was having stimulation of one follicle. I don't want to hyper respond. I want to give only 50 IU. Then recombinant, because it comes in the pain, you can titrate the smallest dose. Second important thing is with the urinary, patient comes to your clinic. 75 also they will not take at home. Here it is a pain. So those who are working in a IT, especially in metro cities, far away distance, just to come all the way for 1 hour, 2 hour travel, you might as well take a pain and 50-50 unit doses at home because it's easy administered. That's it. Otherwise, nothing. Now with agonist, let me start with the agonist. I don't know whether I should cover agonist, but low dose protocols. I'm not giving you all these protocols which are spoken so much. What I do in my practice, let me talk about it. This is a threshold concept I make all my fellows understand, and they decide the dose. We have to give recombinant above the threshold. Now, if the patient has unexplained infertility, it may be a male factor, but an oligofollicular growth, I might give her a dose above the threshold level because I want to rescue all these 2-3. If she is normofollicular, then I don't want to go so high. I will decrease definitely a dose. And if she is a PCOS, naturally my dose will be little absolutely low over the period. So you have to see not only the weight of the patient, you also have to see her AMH, but more than AMH, her AFI. If her AFI is very poor, you may want to rescue 2-3 follicle. You have to give about the threshold level. So when to start and how much dose to give, if you understand, I don't think you need any more help in this. And evidences, again, I'm talking the same clinical pregnancy rate, the same, whether you choose any Cochrane evidences says. I'm going to skip this side. Now here I'm coming. Gonadotrophins, anti-estrogen appear to be cost effective, so you give, although less effective with gonadotrophin. When gonadotrophin is given, it is given on daily basis. This is very important. I don't do this routinely in my practice. What do you mean by that? So now imagine there is a beautiful paper by Tulandi who has compared the gonadotrophin daily with gonadotrophin alternate day And he showed that gonadotropin daily, his success was like 34 to 40%, while with alternate day, it was 20-24%. I don't remember the exact, but it was half than that. But when I read the paper completely, what I realized it, he was giving only gonadotropin and no oral ovulogen. We give oral ovulogen. We have to make our IUI cycle as cost effective as possible because these are not sponsored cycle. So what I feel is I'm starting letrozole on day 3. On day 4, I give gonadotropin. I feel letrozole has given me one follicle. I'm rescuing. Endogenous gonadotropin is getting stimulated. I'll give on day 6 and on day 8. On day 8, I will see the sonography. If the follicles are beautiful between 12 to 14, I'll continue alternate day. Okay. But if the follicles are 10 mm, 11 mm, I know the need of FSH is higher. I have already rescued these follicles. Now from that day, I start giving every day. So there is no hard and fast rule. When you are doing your own sonography, you have to mimic what the follicles want. They want more gonadotropin, and that's why they are not grieving. I will start daily. So I decide, I individualize protocol, and I make all my team members individualize this protocol. And I felt that if Tulandi's paper would have been along with oral ovulogen, his result would have been different. Low dose protocol do not differ significantly in success when compared to high dose. So please don't give high dose. No role of agonist in IUI program because they increase the cost. So no agonist should be given. No difference in the probability of conception, whether one use recombinant or urinary. Now antagonist. Where do I use antagonist? Now we all know that when the follicles are 2, 3, the E2 values getting secreted from each follicle, suppose they are 14, 15 mm, 100, 100, 100, it became 300. Now, the pituitary doesn't understand the estrogen is coming from one follicle or 2, 3 follicles. The level gone about 200, the LH surge will start. Now, the LH surge has started when the follicles are not yet mature. They are not yet dominant. So I don't want that LH surge to come, and that is why I have to add antagonist so that I stop pituitary LH. Now, when I add antagonist and I stop pituitary LH, I stop pituitary FSH also. So naturally, I will deprive the follicle of FSH and I'll make them go back to atresia. So whenever you add antagonist, you need to see that you are giving gonadotropins every day till the day of a trigger. That is the role of GnRH antagonist, which prevents the premature LH surge. So whenever the follicles are more than 2, 3 mm, 2, 3 follicles, they are becoming dominant, especially the 3 follicles or 4 follicle, and you need to add antagonist at 14, 15 mm size. Should analogs be used in IUI? I have told you about the agonist. It becomes expensive, while the antagonist, LS surge, is an absolute requirement for a final maturation, and premature LS surge happens in 25 to 30% of stimulated IUI cycle. And that will interfere with your timing of IUI, cancellation, everything. And that is why it is. So premature LS surge, when especially you are using gonadotropin, don't take it rightly. And you have to use it antagonist, as I told you. So agonist, I'm going to cancel off antagonist from in 2011. The Cochrane was saying the pregnancy rate is same, but the Cochrane changed after this ISHRE group who have published, and they said that GnRH antagonist gives 1 additional pregnancy over in 20 cycles, and probably one can think about. Most important in stimulation is we have to induce follicular maturation and ovulation. So urinary gonadotropin, 5,000 to 10,000, or recombinant or GnRH 1 milligram. When you give a GnRH, you know that SCG has a long life cycle, up to half-life up to 7 days. Before then, the corpus luteum will take over. So SCG is working and then the corpus luteum. While with GnRH, the half-life is just 36 hours. So you should be protecting the luteal phase. That's very important. And if I have to talk about the summary, this is what one can think about: weight loss, lifestyle management, PCOS. Don't start the treatment. I never start unless they go and give 10% weight loss. I send them back for 3 months, though they come 4 weekly for weight checkup. I'm not bothered if they leave me and go next door, because they will fail and come back to your door again. Don't bother. Don't start yourself. Letrozole or CC, pregnancy, fantastic. No ovulation, PCOS, add metformin. Still no PCOS, give gonadotropins. If letrozole, no concern about the pelvic or tubal health, it may be appropriate. If you feel like you are not getting pregnancy, go for a laparohysteroscopic evaluation. These are the few recommendations. When is the ovarian stimulation required in IUI cycle? Yes, to time the cycle, you need to do with the ovarian stimulation. Strong recommendation about it. Is luteal phase required? Yes. When you are using gonadotropins or GnRH analogs, you need to give luteal phase support. There is no second thought over this. So friends, in infertility, individualization of each case is important in order to ensure the excellent results. Before I leave, I just want to appeal all of you to bless me for this forthcoming Foxy presidential election, which will happen in August from 1st to 10th August. Your blessings, your love, your support is all important for me. And I never end without thanking my entire team, who is my strength. And I think these are the fellows who teaches you, who makes you read every day with hundreds of their questions. And they read and they ask the questions, and then you need to answer. So they are the reason why today I stand here. Thank you so much.
Thank you so much, Smita Madam. It was a very elaborate and a very descriptive method of how we should start with the ovulogens, how we should treat the gonadotropins, and how we should get good results out of the same. Thank you very much, ma'am.
Thank you, ma'am.
Thank you, ma'am. We are all with you. There is
Thank you, Kalyan.
Thank you
so much.
In Maharashtra. Don't worry, ma'am.
All our best wishes are with you, ma'am.
All our best wishes are with you, ma'am. And we salute your enthusiasm, ma'am. I have heard your lecture at 4 o'clock in the regenerative medicine also, ma'am.
And now, Pravaha. And
So now we go on to the next speaker for today. We have none other than Dr. Megha Kamlapurkar from Gulbarga. Madam is an expert in ultrasound, and she will be enlightening us today on endometrial Doppler and follicular USG. Over to you, madam. Kamlapurkar madam is a gold medalist in Marathwada University from Aurangabad. She has presented many papers and posters. The worthwhile is one in the Congress of Fetal Medicine in Spain in 2019. She teaches ultrasound to many students, and she has been the chairperson of Fetal Medicine and Genetics Committee at KSOGA, and she has been president of ISOPAP Kalburgi chapter recently in 2023. Over to you, madam.
For me, her last line is more important. She is BA in Sangeet. Wow, Megha.
Thank you, ma'am. Thank you so much. Can I share my...
We have heard too many of her songs also, actually.
कल्याण मेघाला बोलवा ना आपल्या कॉन्फरन्स मध्ये कल्चरल प्रोग्राम हर सॉन्ग्स आर इम्पॉर्टंट मल्टी टैलेंटेड
Yes, ma'am.
Is my screen seen?
Yes, just make it full screen.
Is it okay? Is it seen?
Yes,
ma'am.
Okay. At the outset, I would like to thank Dr. Kalyan and Dr. Pardesi sir for giving me this opportunity for being with the stalwarts in this field of infertility, like Dr. Sunita Tandovarkar Madam, Sneha Bhuyer Madam, Dr. Rajiv Dabde Sir, Dr. Kalyan himself, and all others. And I know, we know that ultrasound has become an indispensable tool in all phases of infertility management. And I have today made a little change in my topic. Rather than endometrial Doppler, I have included this in follicle monitoring by ultrasound. And I remember in 2001, I was given an option to talk on infertility in our society. And that time, somehow I selected to talk on endometrial receptivity and endometrium in infertility. In 2001, where that was an era of slides, and I had to go to Hyderabad to prepare my slides, and talking about endometrial pin codes and receptivity, that has kept my interest still alive when I do ultrasound for my infertility patients. So obviously, before we investigate and treat the couple for infertility, we need to be thorough with the anatomy, physiology, pathophysiology, and hemodynamics of reproductive organs, and that will help us in management. And this is very important slide, as I feel. We need to know what are the primordial follicles, and when we talk about ovarian reserve and the treatment for it. So ovarian reserve is decided by primordial follicles. So these primordial follicles, and the number of these primordial follicles is decided in fetal life, and we all know that declines as the woman ages. This primordial follicle then becomes primary follicle in about 120 days, and then secondary follicle before it becomes as an antral follicle, which measures 2 to 5 millimeters. And these are the antral follicles which are seen in the ovary, and which we count for having an antral follicle count and predict her ovarian reserve. These antral follicles, then they respond to gonadotropin. They are gonadotropin dependent, and then they become recruited, and out of this recruited pool, a few or one or two become dominant, and then they ovulate, rupture and ovulate. Human life is meaningless without harmony and synchrony, and this is true for our follicle study, and where the ultrasound helps us to look into this harmony and synchrony by ultrasound. So what are the reasons to monitor these follicle changes? It is to monitor the natural events that are occurring in the menstrual cycle of a woman, which will decide the management for not only for infertility, but other gynecological problems also. It will help us to evaluate if the dose which is being used for ovulation induction is optimal. It will help to adjust the dose in hyper or poor responders. It will help to find the optimal time for ovulation trigger, which is the key factor for success of ovulation induction. It will guide us when to do IUI and at what time. It will help us to avoid excessive stimulation and thus prevent the deadly complication of ovulation induction, that is OHSS and multiple pregnancy. So then how to monitor these cycles? We all know we are doing it day in and day out. And the complete cycle is evaluated by ultrasound, and you will all agree that single scan is not sufficient. Many times we get patients from villages, and they say us that we stay very far and it's very difficult for us to come 2 to 3 times in a month. But we have to make it very clear to them that all over the world the treatment is same. So wherever you are staying, you have to come not as per my convenience, neither as per your convenience, but it is the convenience of that follicle which is growing, and we have to track it. Of course, transvaginal sonography is mandatory, as we may be losing 42% of the details of the ovaries by transabdominal scan. So always transvaginal scan is mandatory. And these all scans are, of course, 2D. We need to have color Doppler nowadays with us, though we don't have a luxury of 3D and 4D ultrasound. The Doppler is mandatory because the biochemical changes that are occurring in the menstrual cycle are reflected as vascular and morphological changes in the uterus and ovaries. And this can be picked up by Doppler, and we will come to the Doppler settings in next few slides. The scan approach, how should we approach for this scan? Every scan, I feel we should feel this as a first scan in each cycle. So whenever patient comes, we have to see as if I am looking for the first time for this patient, because we should not have shortcuts only to look for follicles and then endometrial thickness and finish up the scan. Obviously, bladder should be empty, because many times the bladder, if it is full, the ovaries are pushed in the abdomen and we struggle to get the follicle size and see the exact follicle which is dominant. We need to examine the cervix, cervical mucus changes that are occurring along with the uterus, ovaries, pouch of Douglas and adnexa as a bird eye view, and then come to the organ of interest. We need to confirm the motility of the pelvic organs along with the bowel and bladder adhesions. We need to focus our area of interest. That is, if we are looking for follicle, just focus on the ovaries. If we are looking for endometrial thickness, our screen should include only the endometrium that is seen in the uterus in mid-sagittary. And of course, we need to document the findings. The machine settings for 2D are easy. We all have presets. If not, then we can ask our application engineers to have special presets for our gynec and infertility scan. We need to have minimum angle and depth of the image. We need to adjust the focal zone and zoom. These are the very important guides when we are looking for the follicle and even the endometrium and the details about the zones of the endometrium. Coming to Doppler settings, for color Doppler and power Doppler, our PRF, pulse repetition frequency, should be very low. That is, it should be within 0.3. This is wall motion filter, which has to be low, because these are small vessels and they have thin walls. And if we increase the wall motion filter, we may miss some vascular changes in this waveform. So we need to have very low wall motion filter and adequate gain and balance that we have to adjust. Here we can see that the wall motion filter is 30. If I keep wall motion filter unknowingly at 90, 120, what we'll be seeing, we'll not be seeing any flow in the diastole. We'll be missing the diastolic flow, and the indices which we calculate will be erroneous. What happens most of the time, if we are in a very busy OPD, we just do one first trimester scan, and with same sitting, we continue to do the next follicle study. Many of the times this happens, and then we don't pay attention to the screen. We never look at what is the wall motion filter. Most of the times it is at 90 hertz or even 120. So this, my important message is to the audience is that we should always look at these parameters and then get the waveforms. Otherwise, if we don't, then we go on struggling to get these waveforms and these indices. So pulse wave Doppler also, these pulse repetition frequency, pulse wave Doppler. Pulse wave Doppler will give us the waveform of a vessel, and during that time we need to have PRF up to 1.3. Here also we need to have less wall motion filter, that is up to 30, and sample volume should be 2 millimeters. We have to ask our application engineers to have these spatial settings for infertility in our machine. When we do follicles monitoring, we are concerned about 3 major scans, like baseline scan, then pre-ovulatory scan, and the post-ovulatory scan. The baseline scan, as we all know, that it's done on day 2 or day 3 of the cycle, when the ovaries, they don't have any active follicle, and we need to confirm that there is no any residual follicle which from the previous cycle. At this time, because estrogen and progesterone are at the lowest level, as we see in this graph, the endometrium has to be thin, and we need to confirm the endometrial thickness. If during this time endometrium is thick, then that indicates that there is an estrogen predominance, and that's why the endometrium is thick, and we need to consider the option for ovulation induction. This baseline scan will help us to classify the ovaries in one of the 4 categories. Like Are they normal ovaries, or are the ovaries PCO? Or the ovaries they have low reserve, or they are really poor responding ovaries, because it predicts the ovarian reserve and response, which is going to help us to decide the stimulation protocols. Especially in gonadotropin induced cycles, we need to see what is reserve. Reserve is the what are the number of follicles that may develop or will likely to develop, or that may be retrieved. That can be predicted by AFC, antral follicle count, or ovarian volume. Whereas response means the dose which is needed to produce one or more follicle, which will be decided by the intra-ovarian flow, that is the Doppler flow. So in IUI cycle, main concern is for multifollicular growth and risk of OHSS. So we need to use Doppler in baseline day to scan. So in baseline day to scan, we need to measure the ovarian diameters and volume. We all know that the normal volume of ovary is from 2 to 3.5 centimeters. Diameter is 2 to 3.5 centimeters, and volume is up to 6.6 cc. The stromal RI of ovary we need to see with all the previous settings, and they should not exceed 0.7. Stromal RI of ovarian stroma, it should be 0.6 to 0.7. Same way, we need to see that the peak systolic velocity of stroma should not be more than 10 centimeters. So it is between 5 to 10 centimeters per second. And follicle numbers per ovary, as we know, that it should not exceed more than 10 to 12. So these things we need to confirm for normal ovaries. For ovarian diameter and volume, we all know how to do that. We can use this screen left and right, and just we have to look for the 3 dimensions of the ovaries and measure, and automatically your machine will give us the ovarian volume. We need to, when we take ovaries in AP view, we need to rotate the transducer at 90 degree. So exactly we'll get the width of the ovary, and together we'll be getting the volume of the ovary by the machine. So we know that enlarged ovary, when we call it as an enlarged band, the diameter is more than 3.5 centimeters, or the ovarian volume is more than 10 centimeters. We call them as the polycystic ovarian morphology. Coming to antral follicle count, we know that it's a good surrogate marker for ovarian reserve, and it's very helpful for the management of infertility, especially in the ART procedures. It helps in predicting the risk of menopause or premature menopause. It can help us to know the ovarian reserve. It will help us to raise the suspicion of ovulator dysfunction secondary to hyperandrogenism ovulation and anovulation. But for this to be very precise, to have antral follicle count, we need to have at least 20 to 40 supervised examination. So we ourselves should audit our reports. So we should, from tomorrow onwards, we can go back and start counting how many AFC I have done. And so after 40, we'll be really expert in giving the exact follicle count. Because every time we need not use 3D, 2D itself also can be useful. So this is these are the guidelines which you can just have a screenshot, and then we can just paste beside our scanning machine, and then we can follow it in our daily routine. And from tomorrow, we can just follow this protocol for noting the AFC. So though we have luxury of 3D ultrasound where we can have AFC, sono AVC, machine automatically will count the number of follicles which can we can select manually or automatically. We can select or delete the follicles. Suppose we are seeing a vessel besides, that also will be counted as a follicle. So we can have an option to delete that, and we can get the correct number of follicles which will be given in the report also. Inversion mode is still a better mode for AFC count, and all these we can try ourselves and get used to that. So total AFC is used for assisted reproduction center generally, whereas FNPO, that is follicle numbers per ovary, is more useful in gynecological practice. So FNPO is follicle numbers per ovary. We need to know that. So FNPO is inversely proportional to BMI and fasting insulin levels, obviously. Why we need to count ovarian follicles? Because as we have discussed, it is going to predict the ovarian reserve. It is going to predict the response to ovulation induction. It will assess the chance of predict the chance of pregnancy following IVF. If AFC is less than 5 to 7, it is associated with small number of oocytes retrieved and with reduced pregnancy rate. Whereas a total count of AFC more than 20 is related to exaggerated ovarian response, and there is a high risk of ovarian hyperstimulation syndrome. In this image, we can see the ovary, right ovary and left ovary. By eyeballing also, we can see the number of follicles is obviously very less. In doing AFC, we should not, one important tip is that we should not rotate the transducer. So if I am seeing the ovary in longitudinal plane, we have to just take longitudinal sections of the ovary, go down and up and down and up and down, and by visual impressions, you should be able to give the number of the follicles. If we rotate the transducer, then we'll have confusion in counting the follicles. So always counting of AFC in one plane. That should be practiced. I'll not go in the details of these Rotterdam criteria for PCO and all, because that everybody knows, and my topic is for ultrasound. So morphological features of PCOM or polycystic ovarian morphology is the number of antral follicles and the arrangement of the follicles with the stromal architecture that we see on ultrasound. And these are the criteria to define polycystic ovaries on ultrasound. When we see the ovarian length is more than 3.5 centimeters, or the volume is more than 10. Sorry, here it should be more than 10. The number of antral follicles or per ovary, if it is more than 12. Hyperechoic predominant stroma. We can see this hyperechoic stroma as compared with the ecotexture of the follicles. We can easily make out how is the stroma. Then we can just put on the Doppler and see how is the stromal flow, and we can calculate the stromal flow Ri, which should not be more than which should be within 0.58, and intra-ovarian stromal peak systolic velocity, as we have shown here. This peak systolic velocity we can measure. Along with that, we can have the uterine artery Doppler, and we can see how is the endometrium. Atypical endometrium is very commonly seen. That means thick endometrium will be seen in cases of PCO rather than thin endometrium, which we expect in the baseline scans. There are studies where the stromal area and ovarian area ratio is being calculated, that can be included, and the stromal volume and ovarian volume ratio more than 75%. But remember that all features will not be getting in a single patient. So if out of these few features are seen along with the clinical history, then we can say that this patient is a case of polycystic ovary. Third category for this is poor responding ovaries. When we call that these ovaries are not responding, irrespective of the size may be normal, but the stromal flow Ri is more than 0.7. Here it is 0.8. It is day 2 scan, and we can see this is peak systolic and this is the end diastolic. So machine automatically will give us Ri, and we can just see what is the Ri of it. If Ri is more than 0.7, then these have low vascularity, and hence they will need, because there are less vessels which are reaching the stroma. Obviously, the drug what we are giving will not be able to reach the ovary, and that's why we may need high doses. So stromal peak systolic velocity, or PSV, is predictive for ovarian responsiveness as the reference. Then when we call the ovaries as low reserve ovaries, when the size is small, when in less than 2 centimeter in the longest diameter, or when the volume of the ovaries is less than 3, or when we see that AFC is less than 3. With any of the stimulation protocols, these ovaries will produce very less follicles, and we can just talk to the patients. A small diagrammatic representation, like poor responders may have normal size ovary, but a stromal flow is more than 0.7 and peak systolic velocity is less than 5. the less number of vessels are invading the stroma, low vascularity. Therefore, these patients, irrespective of the normal size of the ovary, may need high doses. Whereas these are poor responders. Whereas in right side, these are the low responders where size is small, volume is small, count is small, very few follicles are seen, will be getting even after the stimulation. So these Doppler indices, as we have discussed, this RI is systolic minus diastolic divided by systolic, and PI is systolic minus diastolic divided by average. We need not worry much about this. Only thing is that when we have high resistance flow, as in uterine artery, we take into consideration PI. Whereas the small vessels, stromal vessels or endometrial vessels, where the diastolic flow is less and resistance is less, there we consider the RI of these vessels. So this is an example where the uterine artery RI is 0.77 on day 2. So this is definitely a more RI. Here I have taken this as RI, but whereas PI is 1.85. But this is on day 2. We can as well see this before the ovulation trigger. After ovarian assessment in basal scan, that comes is the assessment of the uterine cavity and endometrial cavity on day 2 scan. We need to know the shape of the cavity. Are there any intracavitary lesions like endometrial polyps? We can see this as an endometrial hyperplasia with a spatial blood supply. This is a 3D rendering image where we can see a feeder vessel also. We need to see the endomyometrial junction because this is going to help us to predict the endometrial receptivity. The greatest advantage of 3D is that we can see coronal plane in 3D, whereas we cannot see coronal plane in 2D. We can see only AP and axial planes on 2D, and 3D has this advantage. We can see details of this, especially in the uterine anomalies. It is very important to know which type of anomaly it is with this 3D scan. After the endometrial cavity, we need to know the length of the uterine cavity. When the uterine cavity length we consider, it's from fundus to the cervix along with the cervicouterine angle. But when we consider this from the fundal part of the endometrium to the cervix, it is called as a functional endometrial cavity or physiological endometrial cavity, because that will be helpful for us in procedures like endometrial transfer, embryo transfer or IUI. In basal scan, if uterine PI is more than 0.7, that indicates high doses of stimulation will be required for these patients for endometrial maturation. This is also day 2 scan where we can see many of the blood vessels, they are entering the endometrial cavity, and we can see like a triple line endometrium on day 2. That means that there is an estrogen phenomenon, and we will not get a receptive endometrium if we stimulate this cycle. If this is a 4D rendering image, whereas we can use simple Doppler also. This is power Doppler. In power Doppler, we are not worried about the direction of the flow, but we are only worried about the flow, vasculature, it is there or not, and we can use power Doppler for such cases, especially in the endometrial blood flow. So here, the day 2 scan we have seen, and here endometrial, we can visual also impression, we can see that how much is the diastolic flow and what is the RI, what is the PI, we can very well document. So after first basic scan, it is the pre-ovulatory scan. We start doing the follicle study from day 9 onwards, and we all know that follicle ideally has to be measured in three planes like XYZ. So as we measure gestational sac, but in our routine practice, because of number of patients we are seeing and time constraints, we see that only one section we do and we take 1 or 2 measurements. That's it. But ideally, it should be the 3 measurements which should be included for the follicle size. So antral follicle, of course, it is the antral follicle more than 10 millimeter, at least in 2 diameters, is called dominant follicle, and we know that it grows by the rate of 2 to 3 millimeters per day, and as per that, we call the patient for next scan. Ovulation occurs generally around by 18 to 20 millimeters, and then mature follicle will be surrounded by thin rim with thin wall but echogenic, and we can see a sonolucent halo that appears in the follicle before ovulation. So we can see a sonolucent halo before the ovulation, and we can see sometimes the cumulus operus which precedes the ovulatory changes. If we put the Doppler, we can see that the follicle we should have ideally more than 3/4 of the blood supply. Here, what is happening? The Doppler rays are directly perpendicular to this wall. That's why we are not getting flow in this wall. So in that case, we have to change the angle of the Doppler and see follicle blood supply from all the sides. It should be more than 3/4 of the blood supply. And here we can again put the pulse wave Doppler and have the indices, and we need to see.
Hello, ma'am.
Yeah.
I'm sorry to interrupt, but we'll have to wind up the lecture in the next 2 minutes because we still have one more lecture and panel waiting, ma'am.
Sure. Okay.
Yes,
so these are the Doppler changes, and I'll just keep with some slides. We can you can just have the references if you want through these slides, but these are the pre-ovulatory changes which will help us to decide the time for SCG trigger. So rising PSV and low RI, these are the size for follicle rupture, whereas when peak systolic velocity of the follicle starts decreasing and RI starts rising, we should suspect that this follicle is going for LUF. This is a very good protocol for thin endometrium. We need to know what is the reason, and according to that, we need to treat this. So ovulation trigger point, we can just decide by the proper ovulation study. Of course, OHSS is very deadly complications, and as I have told, we need to put the Doppler study and predict this during day 2 scan. Endometrial grading, we all know that we need to see the triple line endometrial before the ovulation changes occur, and along with that, we can see the uterine artery PI. So uterine artery PI should be less than 3 to start our trigger and to say that the endometrium will be receptive if ovulation occurs. So Doppler assessment of the endometrium gives us a beautiful grading. This is Applebaum's classification for endometrial maturity. And what I would like to say that you start doing on your own, then you will be able to pick up these beautiful pictures. It's not, if I'm able to do, you also will be able to pick them up. It's not very difficult. It's just a matter of the practice. So we know that endometrium, more than 7, we need to have at least 7 millimeters of endometrium with good endometrial flow. So anomalies of the endometrium, I'll not go in detail. Post-ovulatory scans, we should do that, and we should always confirm that there is no LUF, and we need to see that corpus luteum is there, and how is the endometrium. As the endometrium now that was triple line, has it become decidual? That means all the 3 layers are now hyperechoic. So we need to see this LUF. So coming to this end, we know that now in the hands of an experienced operator, ultrasound alone suffices cycle monitoring with no necessity for additional hormonal estimations, which are really expensive for the patients. And I'm really thankful for patient hearing. Thank you very much. So catch the egg, hatch by passion. This was a bird that delivered in the window of my bedroom. Thank you very much.
Thank you very much, Megha Madam, for that elaborative talk on ultrasound use in follicular monitoring and expressively timing the time for HCG injections. May I now call upon the next speaker for today, Dr. Meenal Chitgupkar, who will be telling us about the use of prebiotics in infertility. Dr. Meenal Chitgupkar is Director of Chitgupkar Hospital Private Limited, and she has had 12 years of experience in infertility and laparoscopy. She has done fellowship in reproductive medicine and advanced laparoscopy from NHS England. Over to you, Dr. Meenal.
Thank you. Thank you. At the outset, I want to thank you organizers, Dr. Pardeshi sir, Kalyan sir, Shembekar sir, Dabde sir, and Buyar madam, and our star and talented Dr. Sunita Tandurkar madam for giving me this opportunity to deliver a lecture on a very novel molecule of this lactoferrin in the webinar of infertility, which is organized by AMOGS and MSR. Thank you. Today, I'm going to discuss about a very important topic, that is a lactoferrin. It is a new alternative in the reproductive disorders and preterm labor. Preterm birth is defined the birth between 20 weeks of gestation up to 36.6 weeks of gestation. 10% of women with the clinical diagnosis of preterm labor actually give birth within 7 days of presentation. Now, it is like in 2022, can you see?
Yes,
Hello?
slides are.
Yeah. In 2022 scenario, according to WHO, 10 countries are with the greatest number of preterm birth, and India is topping that, and it has a substantial number. So we need to worry about this preterm birth. Now, lactoferrin is one molecule we are going to discuss today, is an iron binding protein, and it is found in the human secretions such as breast milk, especially in the colostrum, seminal fluid, uterine secretions, tears, and saliva, and has multi-functional capacity, which has a different effects like anti-microbial effects, anti-carcinogenic effect, regenerative effects, and also it modulates the immunological system, antigen presenting cell function. Lactobacilli. The mode of action is lactobacilli are able to inhibit pathogens in the direct manner by co-aggregation or by producing active components such as bacteriocins, lactic acid, and hydrogen peroxide. In addition, they promote the integrity of the epithelium of the by stimulating the mucus secretion and modulating the immune response, which are indirect ways of inhibiting viral and bacterial pathogens. Lactoferrin and lactobacillus species, the pivotal component of first-line defense in female mucosal genital tract. It is involved in the protection against a multitude of microbial infections and the most effective natural mechanism to dampen inflammatory processes. Both lactobacilli and lactoferrin can inhibit the adhesion and consequently the microbial entry inside the cells, appear complementary since lactobacilli inhibit microbial intracellular replication and together with the lactoferrin hinder the infection of still healthy cells. This close cooperation is also exerted through their anti-inflammatory function. The lactoferrin and pregnancy, lactoferrin concentrations have been reported to be higher in mucus of pregnant women than of non-pregnant women. This observation is consistent with the local role for this protein in mucosal immunity. Lactoferrin concentrations are dramatically elevated in context of intrauterine infection in both preterm and the term gestation. It is postulated that protein participates in the host defense against intrauterine infection by controlling microbial growth and modulating the inflammatory response. Lactoferrin in pregnancy and preterm birth. Lactoferrin, due to its anti-inflammatory activity, especially against interleukin-6 axis, has been demonstrated to be a promising candidate for PTD treatment. In clinical trial, preterm delivery unrelated to cervicovaginal infection was treated with the combined administration of oral and intravaginal lactoferrin. Lactoferrin was found to be an excellent treatment in preventing PTD by decreasing both cervicovaginal interleukin-6 and prostaglandin F2 alpha, the main activators of both uterine contractions and membrane ruptures. In other studies conducted on the pregnant women showing high level of pro-inflammatory mediators in AF, a single intravaginal lactoferrin administration 300 milligram 4 hours or 12 hours before amniocentesis was surprisingly efficient in partially decreasing some mediators of pro-inflammatory process, including interleukin-6. The bovine lactoferrin in preventing preterm delivery is associated with sterile inflammation. It has shown that combined administration of oral and intravaginal lactoferrin to the women cohort with the PTD threat decreased interleukin-6 in both serum and cervicovaginal fluids, cervicovaginal prostaglandin F2 alpha, and suppressed uterine contractility. Lactoferrin administration blocked further shortening of the cervical length and the increase of the fetal fibronectin, thus prolonging the length of the pregnancy. So it provides strong evidence for a role of lactoferrin in PTD treatment, thus extending the therapeutic potential of this multifunctional natural protein. Lactoferrin and pregnancy outcomes in the patients with the refractory bacterial vaginosis is like 6 women with a history of multiple pregnancy losses or the preterm delivery and refractory bacterial vaginosis who received probiotic LF therapy. The vaginal lactobacillus was either absent or very scarce before LF administration, and vaginal suppositories and LF given in 2 patients, refractory vaginosis treatment and BOH. Oral lactoferrin administration in to 4 patients was given and the pregnancy outcome was evaluated. So the result were lactobacillus that appeared after 1 month to lactoferrin administration gradually become dominant and 5 patients became pregnant 3 months later. All pregnant patients achieved the desired outcome of a normal delivery without complications. The findings from these 6 patients suggest that administering lactoferrin to human could help prevent refractory vaginitis, cervical inflammation, and preterm delivery. The influence of lactoferrin in preventing preterm delivery, a pilot study where 21 pregnant women aged between 22 and 36 years suffering from IDA at risk of preterm delivery were prospectively enrolled in the study. One group, like 14 patients, received 100 milligram of bovine lactoferrin before meals before 1 month, and control arm, other group, received 520 milligram of ferrous sulfate. The pregnancy outcome evaluation was done. The results of oral administration of 200 milligram of lactoferrin resulted in normalization of vaginal flora, vaginal infection disappearance, decrease in the interleukin-6 cervicovaginal fluid levels. The ultrasound data, cervical length and funneling did not change at follow-up after 10 and 30 days. Pregnancy continued regularly in both groups. All women had birth at term after 37 weeks. So administration of this lactoferrin for women with refractory vaginitis, recurrent preterm deliveries, and an appearance of lactobacillus in vaginal flora, followed by the term delivery, was done. And in that, we administered in this study, it was administered vaginal tablets and oral agents of prebiotic lactoferrin, resulting in lactobacillus prominent vaginal flora. When she was pregnant, she was continued to use this lactoferrin, and the lactobacillus in the vaginal flora was continuously observed during the pregnancy. And it was observed that because of administration of lactoferrin was discontinued after delivery, lactobacillus in the vaginal flora was disappeared. So there's another component like the fructo-oligosaccharide. This is also prebiotic. It is non-digestible polysaccharide. It promotes growth of beneficial bacteria. The oligosaccharides that occur naturally in the medicinal plants such as onion, garlic, asparagus, banana, and FOS is used to improve the dysbiosis by enhancing growth of bifidobacteria. It also has shown to decrease the growth of potentially pathogens and enhance the immune system. In the vaginal ecosystem, it is presumed that symbiotics have the capacity to optimize, maintain, and restore the natural microbiota of the vagina. So in summary about this molecule is lactoferrin and lactobacilli combination can help to address higher inflammatory markers and normalization of vaginal flora, and it minimizes the risk of preterm birth. Thank you.
Thank you, Meenal, for that elaborative talk. We now move on to the panel discussion. May I call upon the moderators for the panel discussion? Dr. Kalyan Baramde sir and Dr. Raju Dabde sir.
Bijal, can you please put the slides, please? Bijal, are you there?
Bijal?
Yeah, please share the slides for the introduction. The moderators first, please.
The moderators for today, the panel discussion, Dr. Kalyan Baramde sir. He is the secretary IAGA. We have already introduced him. The next moderator for today is Dr. Rajiv Dabde sir. He is a private practitioner, infertility consultant at Navjeevan Fertility, assistant professor at Ashwini Rural Medical College, and he has presented research papers on Shirodkar sling, diagnostic laparoscopy in abdominal tuberculosis, learning safe endoscopic hysterectomy, and safe entry into peritoneal cavity. Our panelists for today are Dr. Supriya Birajdar, who is again working at Navjeevan Fertility and IVF Center with Dr. Rajiv Dabde sir, and she is a practicing gynecologist at Birajdar Hospital and Krishnamai. The next panelist for today is Dr. A.P. Rane, who is a director of 100-bedded multi-specialty hospital at Apex Hospital, Akluj, for the past 10 years, director of First Rural IVF Center, Akluj Fertility and Test Tube Baby Center for the past 4 years, special work in high-risk pregnancy and internight ligation in rural setup, current General Secretary of Akluj OBGY Society, past Clinical Secretary OBGY Society of Akluj, and she has been an IMS State Director of Mission Pink Health, author of article on triggers and IVF in Mog's Infertility Handbook and Obesity in Pregnancy chapter in Foxy Medical Disorders in Pregnancy. Our next is, I'm also a panelist for today. Next panelist is Dr. Sudesh Joshi, who is very close to the Solapur OBGY Society, a senior obstetrician and medical legal consultant, working for the past 25 years in the rural setup, and he has delivered around 12,000 babies in his nursing home. He is a chairperson of Medical Legal Committee 2022 and past president Pandharpur OBGY Society, vice president IMLEA, and chairperson of Adolescent Health Committees 2016-18. Dr. Sudeep Sambaram has joined us. He has done his MBBS from BJMC Medical College, DNB from Mysore, and has finished his fellowship in reproductive medicine from Natkani Institute, Gujarat. He's a consultant infertility specialist at Apollo Hospital, Solapur, and at his own hospital, Sambaram Women's Clinic and Maternity Hospital. We have Dr. Anuradha Garad with us today, who has been my senior resident while I was in Noshivara, Mumbai. And she has finished her DQ, PFP, DNB, FCPS, and has done her fellowship in infertility from WAPI and advanced USG training. I welcome all the moderators and panelists for today. Over to you, Kalyan and Dr.
Thank you for such a nice introduction of all panelists. Why I can't see my PPT?
Can you please help?
I know it is not getting open in the Zoom platform. Just give me a second, please. Can I see it now? No.
Not yet, sir.
Just wait, because I'm going to share screen. Now I can't see the option.
Share screen option in green at the bottom of your
screen. I know. See, I have press the share button, but I can't see my PPT. That is a problem.
So you have to get the PPT on your desktop, sir.
I have got it, but it is not getting. Just give me 1 second, please.
Actually, he shared his presentation when we all were still gathering. Okay, Kalyan, by the time you start, I will start with my questions for the panelists.
Yes, sir. Please, please.
Hello. Nobody speaking there? Okay, this is a question. I mean, all the questions are open to all the panelists. And the first question is day 2 scan. Okay. And we find that the residual follicle is more than 15 millimeter. What is your take on this? Anybody can take this. The residual follicle of more than 15 millimeter on day 2.
So can I answer?
Yeah, please.
So when the residual follicle is more than 15 millimeter, we would not go ahead with stimulation. Maybe give her OC pills and wait for regression of this residual cyst, and then call her the next cycle and start stimulations.
The question is, why do you want to wait?
So the thing is, if there is a residual cyst, the estradiol, that is the serum estradiol, will be high, and even the LH, serum LH may be high. So whatever we stimulate, the quality of the eggs may not be that good, sir.
Okay, and the patient has bled. If the patient has bled, very fact that the estrogen levels have gone down. Hello.
Okay.
You can put a color, see the indices, and then decide.
Yeah. So if the color is there and if the color is not there, what is your take on this? Yes, the ultrasound specialist.
Look for the endometrium.
Endometrium is thin. That's why she has bled. Rather, she has bled. That's why endometrium is thin today.
15 millimeter is okay.
Sorry.
We will start.
I can go ahead.
Yeah, except what I read from this, because I have gone through many articles, what I read, except for the physical pressure. Okay, this residual follicle, if it is in hypoestrogenic condition, would not interfere with the stimulation protocol except for the physical pressure. I mean, it may hamper the growth of the follicle, which would have otherwise grown, but this residual follicle may not allow that. And if the endometrium is thin, I think that hormonal milieu should not come in the way of our stimulation protocol. Yeah, Kalyan is ready now.
Yes, sir.
Please.
What is the take-home message, sir? What we are going to do with the 15 mm follicle?
Take-home message: day 2 endometrium has to be thin, and the residual follicle has to be less than 15 millimeter, rather 14 millimeter. And if it is more than that, then you have to really speaking, even without giving the OC pills, this follicle would regress by the time the patient comes the next day. But if you want to this residual follicle, if you are worried that this may prolong the menstrual cycle, in that case, it's wise to give a cycle of OC pills and correlate date of the next cycle.
Yes.
Thank you, sir.
Safe then, sorry.
Yeah. Sorry for that technical glitch. Can you see the slide now, please? This can be slide repetition. Uterine abnormalities like polyps, submucous leiomyoma, intrauterine adhesions, chronic endometritis, and congenital anomalies have been reported in 21 to 47% of the patients who are undergoing IVF cycles. There can be endometrial polyp, uterine septum, or even Asherman syndrome, endometriosis, and infertility, which causes pain. So the first case, 29-year-old lady came to your OPD with history of pain during menstruation with increased bleeding pattern with primary infertility of 3 years. Her BMI is 24. History of regular menstruation in the past, but now complaints of altered bleeding pattern with slight increase in bleeding during menstruation with sometimes mild spotting in between. On examination, normal PV finding. Day 2 hormonal reports are normal. UHG shows small 1.5 centimeter intrauterine solitary lesion. So what is your diagnosis? How are you going to manage this patient?
May I take this?
Yes, sir. Anybody.
One thing is ultrasound. we have to do it twice, once on day 2 and on day 10 to differentiate whether it is a polyp or endometrial thickening. Secondly, I would like to have a look at the 3D of the ultrasound, which will help me differentiate what it is. And thirdly, put color in it. So if it is a polyp, which is causing her symptoms, then we can go for a histoscopic removal of polyp.
Very rightly said by Dr. Sudesh. What AAGL says, TVS provides reliable information for detection of endometrial polyp and should be investigation of choice wherever it is available. The addition of color Doppler increases the capacity of TVS to diagnose endometrial polyp, that is level B evidence. Adding intrauterine contrast to sonography improves the diagnostic capacity for endometrial polyps, and blind dilatation and curettage or biopsy should not be used for diagnosis of endometrial polyp. Now, as this patient is infertile, do you recommend expectant management or surgery? Dr. Anuradha.
Now, this patient needs a surgery because she is bleeding heavily. She has a menorrhagia, intermenstrual bleeding. Then she's 3 years of a primary infertility. So we should better go for a hysteroscopic resection of this polyp. That will be the best thing.
So what is the choice of instrument, whether a bipolar, monopolar, or cold scissors?
We are not doing hysteroscopic resections. So anyone other can take the question.
Dr. Pratibha. Can you unmute, please?
So I feel best is to go ahead with cold scissors because infertility management later on, if we look at the endometrium, growth of endometrium, cold scissors is the best. Less use of energy would be preferable.
That is rightly said. Hysteroscopic polypectomy remains the gold standard. So instrument of choice, if a patient is infertile, a cold scissor is a better option, but there doesn't appear to be differences in the clinical outcomes with different hysteroscopic polypectomy techniques. Now, at time, excellent polypectomy is done, but there is difficulty in the specimen retrieval. What are the problems and how you are going to manage a dancing polyp? Dr. Supriya, can you just come in? Okay, yeah, anybody can take this.
Yeah. About the dancing polyps, once you have the polypectomy is done, and if the polyp is not very big, then if the dilatation is there, it may come out on its own, but the pathological diagnosis may remain obscured. So what at times you can use a simple suction evacuation, which you use for MTP. So smaller cannulas can suck it out.
Okay, sometimes you can, if you are done a removal, you can put a OM forceps. That makes life simple. Secondly, there are certain instruments which can be put through hysteroscope like graspers. They can be used, and a hysteroscope is removed with the grasper. That is another thing. Or even new morcellators have come into the market where if facilities available, hysteroscopic polyps more than 3 centimeters can be removed by the grasper, by the morcellator. So rightly said, whatever way you are comfortable, Sudesh, you are going to use that. How much time you are going to give after polypectomy for conception for this patient? In the same cycle, next cycle, 2 months, what is the time duration?
One cycle of forceps and then next we can do it.
I think
1 to 2 cycles.
Or maybe 2 to 3 months post-operatively, because sufficient healing of the endometrium is what is we are looking at. Because to have good effects, good results for pregnancy and for it to continue long, even the vascularity of the endometrium has to develop. So minimum 2 to 3 months is what we should look at.
Rightly said, minimum 2 months. Now here is another question for everybody. So if it is a vascular polyp, are you going to use still cold knife or bipolar cauterization?
No, if it is highly vascular and if you are seeing the base, even after cutting it with a cold scissors, it's better to bipolar treat.
If there is a spurter after you have removed the scissors, right?
Yes.
Okay, thank you so much. Over to the second case where Dr. Dabde sir will take this. Is a case of yes, sir.
Sorry to disturb. You have
Yes,
shown one slide where some genetic reference was seen somewhere.
Yeah, you want to. Yeah, as such, previous speakers have taken slightly more time. That's why we just that one. So I'll show you the genetic markers which are available for this. HOXA10 and HOXA11 gene expression, which are there with the fibroid also. Also, glycodelin inhibits sperm oocyte binding and NK cell activity. It is speculated that fertilization and endometrial receptivity may be altered by increased glycodelin production in the uterine cavity of the patient with leiomyoma and polyps at the time of periovulatory, when uterine glycodelin levels should be absent or low. So these are the genetic things which you can just refer for theoretical purposes. Thank you.
But for theoretical purposes, nowadays, in this era of genetics, there can be litigation. We need to just give the reference of this and advise patients also.
Yes, ma'am. Thank you.
Kalyan, I request you to continue with your surgical cases, but in between, I'll be taking one clinical case.
Please.
Don't mind.
Please.
So, we all have heard Dr. Sunita Tandavarkar just now, and she mentioned that when you want to shift from clomiphene citrate to letrozole, okay, you have to give a gap of few months because this letrozole can have a residual effect. How many of you agree with that statement? The clomiphene has a residual effect. How many of you agree with the statement that clomiphene citrate has a residual effect in the next 2 cycles? Okay.
Yeah.
I beg to differ with those who raise their hands because I follow Spiroff, and Spiroff says that these 2 molecules of clomiphene citrate, ZU and N. N-clomiphene is active, which is a half-life of 7 to 8 days, and ZU-clomiphene has a longer half-life, remains in the body, but it has no biological activity.
Yes.
Please.
So this is a second case. 34-year-old lady came to OPD with history of profuse bleeding during menstruation with passage of clots, history of secondary infertility for 4 years. USG shows evidence of submucous fibroid type 2 of 3 into 2 centimeter in size. What is the role of 3D ultrasound? What is fibroid mapping?
Fibroid mapping is exactly knowing on ultrasound where the fibroids are located, what is their size, whether they are submucous, intramyometrial or subserosal. The importance of knowing this is that when we go in, we are not in for surprises and we exactly know where we have to dissect and up to what depth can be removed. If the size of the size of the fibroid is more than 3 centimeter and it is not embedding into the endometrial cavity, or if it is not close to the cavity, we better leave it and not approach it hysteroscopically. That can be tackled laparoscopically.
Very rightly said, fibroid mapping plays a big role whenever you are going for a surgical removal of any fibroid. Maybe it's a submucosal, maybe it's intramural or even other fibroids. So we have a FIGO classification where 0 is pedunculated intracavitary, 1 is less than 50% intramural, 2 is more than 50% intramural, and others like 3 is contacts endometrium 100% intramural, 4 is intramural, 5 is subserosal, and all other types. That is very important. And can we predict the success of transcervical resection of myoma? This is a study by Lasmer classification where he takes into consideration the penetration, size and base and third of myoma, whether it's in a lower, middle or upper third, and lateral wall extension. So in this scoring, if the score is between 1 to 4, is a group 1, can be safely done with hysteroscopy. If it is score 5 to 6, then complex hysteroscopy where you have to give guidelines to the patient that second stage might be required for this, and score more than 6 always laparoscopic route. So that is why fibroid mapping is important in these patients. As everybody knows, fibroids need to remove because they do influence fertility, mainly based on favorable pregnancy rate outcomes. Hysteroscopy cannot only diagnose these pathologies, but also enables removal in the same sitting. And how you are doing this surgery, how you are going to manage the excessive bleeding during transcervical resection of myoma. Anybody can take this. Dr. Pratibha?
Whenever there is excessive bleeding, as we said in the case of a polyp, bipolar cauterization can be taken. Bipolar cauterization, we can use little current. But
Right.
But apart from that, there pressure, giving pressure at that site and then waiting for some time. Plus, there are injection pause and all. I do not do TCRM personally, but I have seen a few cases. That is what I have gathered from this. But I think
so here, Pratibha, we like to add, we use vasopressin injection diluted, and that has to be put prior to the surgery into the cervical, and it is going to have two effects. One is going to have less bleeding. Also, it is going to contract the myometrium. Also, that is going to prevent the bleeding. Secondly, as you rightly said, you can do a bipolar cauterization. The bipolar saline is better option, but it causes bubbles. So if you are comfortable, if you want to do it faster, then monopolar cauterization is a good option. But with monopolar cauterization comes the fluid overload. So how we are going to manage the fluid overload, and are there any preventive measures for fluid overload? Dr. Sudesh, Dr. Sudeep, you can add. Dr. Sudeep, you can unmute, please.
Hello. We can always use a histomat, which helps in the flow rate and the pressure inside the uterine cavity, and also we can also have a look on the outflow fluid, the irrigation.
So you are going to appoint one person who will measure the inflow and outflow. And as one specific person needs to be there only measuring the deficit. That is very important point Dr. Sudeep has added. Anything else, Dr. Sudeep?
And mainly the deficit should not be more than 1.5 liter. And a proper check during the monitor at the look at the monitor, so that there is no changes in the breathing patterns or of the patient.
I think the role of, may I add something?
Yes,
I admit that I don't do any histoscopies, but what I would say clinically is the role of the anesthetist is also important. You should be looking at the lungs, auscultating them regularly, so that there are no signs of fluid overload in the lungs, which is going to be catastrophic.
Rightly said, you should use histomat or some technique where which you are going to automatically know what is the deficit firstly. Secondly, one person should be dedicatedly using this. And thirdly, you are not supposed to use these pressure cuffs and BP apparatus where you are going to pump, and suddenly some air bubble goes inside and can have a catastrophe. Thirdly, very important, those cases you should know your limits. If you are going to have a limit of 3 centimeter fibroid, you should decide it prior. And fourthly, if you are going for a big fibroids, you can preoperatively do sodium, potassium, and electrolytes. That is going to give us another advantage in the post-op phase. Rightly said, Sudesh, anesthetist's role is very important. As far as possible, we do these surgeries under regional anesthesia. So the first sign patient is going to give you certain signs. Patient when comes, she is going to tell you that she's feeling heavy or she's having difficulty in breathing. So as far as possible, under spinal anesthesia or regional anesthesia is always better to do these surgeries. And lastly, if the patient had incomplete myomectomy and perforation, what is your next step if you are going to manage this? So similarly, you are going to put a laparoscope as always, because you are using a bipolar quaterization. You see where you are injured. If there is any bleeding, you can do a suturing or bipolar quaterization. You need to trace the bowel so that you are medical legally safe. And if there are any white patches, then you can involve the surgeon and he can do the next step to prevent the medical legal complication. If there is no bleeding, you can very well complete the myomectomy under vision, or you can postpone and can do it after 2 months. So Dr. Dabde sir, your questions please, pillars.
Now we all have seen Dr. Megha showing us the ultrasound picture of polycystic ovaries in their morphology, and we diagnose them as polycystic ovarian syndrome, and we need to put them, optimize these patients before we take them for ovulation induction. And metformin is one of the favorite drug of many to put these patients on metformin and optimize them. So I want to know from the panelists, how many of you would agree that giving metformin as a blanket therapy for all the patients presenting with PCOS features, or would you do the any test to know whether the patient has insulin resistance and then only think of adding metformin? Anybody can take this.
Fasting insulin.
Yes, sir.
Fasting insulin would help.
Yeah, fasting insulin, okay. And how does it tell you that whether the patient has insulin resistance?
Would you like to add metformin? We are not.
Sorry?
If the patient sugars are normal, if the fasting insulin is more, then it tells you that there is insulin resistance. That's why the insulin is more.
So what is that? What? How much is more?
More than 10, I think.
See,
Saran, can I add?
Yes, yes.
Yeah, please go ahead. Somebody was talking. Yeah. Sorry.
No, in our setup, we do a fasting sugar and a fasting insulin, and then we do HOMA IR. But sometimes, not necessarily at every time, the HOMA IR will be 2.5, more than 2.5 or 1.5. But we have to see whether the menses are very irregular and she bleeds only on withdrawal and hyperandrogenism. If these two things are there, then also it sustains that we should add metformin to them.
Yeah, but giving metformin to the patient who doesn't have insulin resistance would just add to her prescription like any multivitamin or B complex tablet. But we have to prove them to be insulin resistant if their HOMA IR is more than 2. And yes, body mass index is one more, because what study we did, those who had body mass index more than 26, all 100% of them had high HOMA IR. So there's no point in investigating these patients with high BMI for insulin resistance. They do have insulin resistance and they require metformin therapy in incremental manner. By incremental manner, I mean we start with 250 milligram bedtime, wait for a week, allow her to tolerate that metformin, then make it twice a day, then wait for 1 week, allow her to get used to that twice a day, and then 3rd week onwards, you can give the desired dose, depending on the BMI, whether you want to go give 1500 milligram a day or 2000 milligram a day.
Sir, I have one question.
Yes, please.
Maybe a little diversion, but I just wanted to know, I don't practice infertility much, but I just wanted to know your experience of using injection liraglutide for weight reduction for such patients, PCO patients.
No, we have not, we do not have any experience.
Because we have 2 patients where they had very high BMI, and then I referred them to endocrinologist. He started them on these injections, and then there was a reduction of 7 to 8 kgs, and that helped me for their treatment. And one of them, she has conceived and she's delivered. So
the only exercise we advise to our patients is of the neck. We tell them you need not join any gym next year or any dietetic restrictions. Just do these lateral movements of the neck. Anybody offering you seats, you just do these movements, and that will help you to reduce the weight. But yes, well taken, Dr. Megha. we can really think of this drug for weight reduction?
Yeah, that is a primary drug nowadays. Even it has come into oral tablets. It has to be started 7 milligram in a first week, 14 milligram in a second week, 20, and it can be given very safely for 3 months. And it causes weight reduction of 3 to 4 kg per month. And you have to continue for 3 months. That is having additional effect that weight reduction is going to cure her PCOD, as well as the dictum that 10% weight loss is going to have pregnancy spontaneously. So moving to the third case of surgery. Yes, sir.
We switch over to case number 3. Kalyan.
Yes, sir. So this case is 32-year-old lady came to OPD with secondary infertility, history of DNC done 1 year back for incomplete abortion. She has amenorrhea of 5 months, UPT done negative, estrogen and progesterone withdrawal, no withdrawal bleeding, imaging showing this picture. So what is your diagnosis? Dr. Megha.
The previous slide.
Previous size is a diagnosis.
Of course, it's intrauterine adhesions, Asherman's.
Yeah, so they can be seen as echogenic, irregular, eccentric lines within the endometrium or as focal narrowing of the endometrial thickness. This is normal. These are the Asherman's endometrial thickness. 2D UAG, 3D UAG is specific. Now I consider question for Sudesh sir. Do we consider SIS or HSG in the diagnosis or proceed directly with the hysteroscopy to confirm the diagnosis? Sudesh sir, आवाज येत नाही.
Sudesh, unmute yourself.
He is unmuted, but yes, Sudesh sir.
No. He has muted probably.
Dr. Pratibha, तुम्ही घ्या.
Sudesh, we can't hear you.
Sudesh, you need to re-log in again.
No. Sorry. Can't hear you.
We can't hear you, Sudesh. You need to re-log in.
It is to make the diagnosis of Asherman syndrome either by an HSG first, and then when we know that there are adhesions, go in planned for a hysteroscopy with a plan of operative hysteroscopy to break the synechiae.
Very rightly said. So you are going to do HSG or saline infusion sonography.
HSG or saline infusion sonography is also fine enough. That can also diagnose Asherman's to a great extent.
Okay, adhesions are characteristically appear as bridging bands of that distort the cavity, and flimsy adhesion described as thin, undulating membranes. What you are suggesting is doing an HSG, which are adhesions are seen as filling defect described as homogeneous opacity, surrounded by the sharp edges and do not change with the positioning of the patient. Hysteroscopy remains the gold standard. The mucosal adhesions are frequently pink-like surrounding endometrium. Fibromuscular adhesions are thicker with the white band. But what AGL says, hysteroscopy is the most accurate method for diagnosing and should be the investigation of choice, level B. But if hysteroscopy is not available, which is not possible in India nowadays, alternative therapies can be used like SIS or HSG. So whenever you have a patient who is not menstruating with either OC pills or estrogen and progesterone, then it's always better to go with a hysteroscope with a preparation of undergoing an operative hysteroscopy. MRI should not be used for diagnosis of intrauterine adhesions. So now Dr. Sudesh has come back. What is your pre-op preparation and what instrument is better? You can see scissors, bipolar or monopolar. All three pictures are being shown. What is your choice and why?
Scissors or scissors would be more useful because in these adhesions, they are very less likely to bleed. They are fibrotic adhesions. So bleeding would not be much a problem. So with the scissors, I think you can go ahead. I would like to make it clear that I am a basic obstetrician. I don't practice hysteroscopy. These are my theoretical knowledge, and that is what I'm telling you.
You are good in theory. Don't worry. So hysteroscopy is always better to use a scissors. Yes. Those where thick bands are there you can use a monopolar current or bipolar current also. As these patients are infertile, they need to regain their fertility also. If adhesions can be removed, better with the scissors. And what is the assisted or guided hysteroscopic adhesiolysis? Does anybody routinely put laparoscope while dealing with Asherman's? And what is the logic?
Only thing is when we are suspecting that there are a lot of dense adhesions in Asherman's and we are suspecting a perforation or maybe we have overshoot, then we would put in a laparoscope, not routinely.
So if you have done a proper 3D ultrasound,
yes,
then there is no need of putting a laparoscope. There is no evidence that hysteroscopic adhesiolysis guided by external imaging or laparoscopy prevents uterine perforation or improves the clinical outcome. However, such an approach used in appropriately selected patient may minimize the consequences if perforation occurs. So these are the post-operative treatment advices. Which is better? What evidence say? And when you do a consider relook hysteroscopy. So always better copper T without copper or a pediatric Foley's catheter. What is better?
Copper T.
Like a Lippis loop, which has a wider area without a copper, or we are giving high dose of estrogen. That is enough for many of the patients because there is no need of giving or putting copper T or pediatric Foley's. But if you are doing an extensive surgery like grade 4 Asherman's, then you can put a pediatric Foley's catheter that can suffice. The number which is used is 5 or 6, and that has to be kept for minimum 3 days, maximum 7 days. So those patients where IUD is used postoperatively, it should be inert and have large surface area. No evidence to support or refute use of preoperative, intraoperative, or postoperative antibiotic therapy in surgical treatment of intrauterine adhesions. These are level C evidence. Follow-up assessment of uterine cavity after treatment is recommended. That is grade B evidence. Regardless of the surgical intervention, use reassessment of uterine cavity, usually after 2 to 3 cycles after surgery, is worthwhile as by ambulatory method like office hysteroscopy. And if there are few adhesions, then you can go ahead with the adhesiolysis. So what again? In COX patient, you need to give anti-COX therapy first. That is important. And after you have finished the therapy, either you can go for a HSG or second look hysteroscopy with operative hysteroscope.
I have one query.
Yes, sir.
Lippis loop has been recommended. I haven't seen a Lippis loop. Has anyone seen or operated or used Lippis loop?
So that is the reason I said Foley's catheter number 5, 6, that is pediatric, is often used because that is theoretically not available nowadays, Lippis loop.
Yes.
But if you are going to use an IUD, that was better because it has a big surface area. So lesser adhesions, you know.
Okay, thank you.
Or to Dr. Dable, sir, please.
Last but one question from my side. As Dr. Megha told in her presentation that whenever we have to think about the trigger, we should look at the follicle. The size should be 18 to 20 millimeter plus with 3/4 of the wall showing the vascularity. And maybe if the peak systolic velocity is more than 10, it should be given. And if it is more than 25, you are very close to the ovulation. Or if there is a halo sign around the follicle, that will also tell you that the follicle is mature. Now, my question to the panelist is, what dose of HCG would you use? Because we have in the market different preparations, 5,000, 7,500, 10,000. What is the strength of the injection HCG that should be used to trigger ovulation?
At least 10,000, sir. We will prefer 10,000 IU. 10,000 international.
Okay. Anybody else wants to differ from what Dr. Anurag Garad has said?
7,500.
7,500. So this question was really troubling me. So I wrote to Dr. Pankaj Desai. And Desai sir said that if we have had difficulty in getting dominant follicle, I mean, if your ovulations, oral ovulations were not working, if you're required to give gonadotropins in higher doses to have dominant follicle, this particular follicle has a greater requirement for SCG also. So in those patients where folliculogenesis occurs easily with, say, your letrozole or clomiphene citrate, 5,000 dose is sufficient enough. But if you require to use gonadotropins, then switch over to 10,000. But as Dr. Anuradha has rightly said, that she is right in saying that we should be using 10,000 because we do not know the cold chain pattern in which the drug was supplied to our medical store, and that may lose the potency. So not to take any chance on the potency of the drug, we can use 10,000. Giving higher dose of SCG is not going to matter as far as the outcome is concerned, unless you are dealing with a case of more than 4 dominant follicles which would land into OHSC, in which case we would not give trigger at all. But one additional thing which I have learned recently is to escalate the action of SCG, we can also add 1 milligram of leuprolide injection. So both will synergistically act and bring about a good LS surge and will ensure the rupture of the follicle, provided your timing of that stimulation, timing of that trigger was correctly assessed by the color Doppler scan. Thank you very much.
So my question is that does septum affects fertility? Dr. Garad.
Depends, sir, if it is a complete septum or a partial septum. I have seen patients delivering with the septum. I have seen 2 patients who had the septum and they delivered vaginally. So the septum was not complete and it has not affected their coital activity or a pregnancy or a delivery too. So it depends upon which type of a septum we are seeing.
Okay, there is insufficient evidence to conclude that a uterine septum is associated with infertility. Grade C evidence. Infertility can be a result of multiple factors and is often difficult to determine if only septum has caused this. But several studies have indicated that hysteroscopic septum incision is associated with improved clinical pregnancy rate, that is grade C evidence of ASRM. Does treating a septum improve obstetric outcomes? Yes, it will improve the outcome. So the most suitable instrument, again, as you are comfortable, Dr. Sudeep, what you use, scissors, bipolar or monopolar?
I would like to use a cold scissor for septal resection in an infertile patient. And then only when there is excessive bleeding, then I would like to go for a bipolar resectoscope.
When you plan the pregnancy in these patients?
After 3 cycles.
After 3 months, 2 to 3 months is a better time.
3 months.
Right. Dr. Dable, sir, please.
Yeah.
Last question.
Last question to the medical legal specialist from the panelist group. Sudesh, now with this new ART law, what is your take on the use of donor sperm for insemination in patients with azoospermia? And what is your take on using donor eggs in patients with extremely poor or almost no ovarian reserve in ART cycles?
Well, if there is severe azoospermia, then we will have to resort to donor semen, definitely. And when the eggs are not there, you will have to resort to donor eggs. But because of the new ART bill, it has become difficult to resort to these things because of new complications and new things. But that would be the answer. But it has become more difficult to do it.
Yeah, that's true. So basically, the law doesn't allow you to use the fresh donors. So there is no question of the patient bringing own donors, and they are now not allowing us to use the frozen samples too, because no bank is supplying them. As far as donor eggs is concerned, still they are allowing the use of fresh donor oocytes. So if the patient can get hold of anybody who can donate for her, as far as the oocytes are concerned, we can still go ahead. But the banks have not yet started functioning. Yeah. Right. Kalyan, go ahead with your beautiful videos. Continue.
Yeah. In between, I am just showing because there is less time. We are about to finish in another 2 minutes or maximum 5 minutes. So now the question remains in PCOD.
Wait on the slide of 4 punctures. Yeah. Wait on that slide of 4 punctures.
Yeah, I'll just come here. 24-year female, married since 3 years, irregular cycles, HAG normal, HSA normal, 6 cycles of ovulation induction with letrozole 7.5 milligram given. There is a ovulation. What is the next step? In which cases you like to do a PCOD drilling?
Only on those cases of PCO which have not responded to those cases of resistant to ovulation, because after using clomiphene or letrozole, and even after using gonadotropins, you're not getting ovulation, it is better to go ahead with drilling, laparoscopic drilling.
Yes, the main goal of treatment is the induction of monoovulatory cycles. A stepwise approach to the management of infertility in PCOS will permit most patients to achieve pregnancy and live birth. Appropriate lifestyle modifications such as diet and physical exercise in order to reduce weight, oral medication agents, and lastly, for women with WHO group 2 ovulation disorders, depending on the clinical circumstances and the woman's preference, laparoscopic oral drilling, combined treatment with CC and metformin if not already offered as first-line treatment, or gonadotropins. And lastly, the most plausible mechanism of action are destruction of ovarian follicles and a part of ovarian stroma also, including reduction of serum androgen and inhibin levels, which will increase the FSH levels and restores the ovulation function. LOD may also increase ovarian blood flow, allowing high delivery of gonadotropins. But when you are doing a PCOD drilling, you have to know the rule of 4. You are not going to do overzealous drilling, like writing your name, like Dabde sir writing D, some 10 punctures, or Kalyan making 10 punctures of K. So the rule of 4 is 4 punctures per ovary of 4 millimeter depth for 4 seconds at a current of 40 watts. Sir, you want to add something, Dabde sir?
Yes. Actually, this slide was shown to me by Dr. Sachin Kulkarni, whom I admire a lot. And then he asked me, he asked the audience actually, why me? He asked, how many of you really count these 4 seconds when you are puncturing? Because everybody feels it. Puncturing, tuck, come back, tuck, come back. That's hardly 2 seconds. From that time, when I started drilling, to count 4 is a pretty long time. 4 seconds is a long time to quatrize. And unless we use that, maybe we will not be able to get the effect of that drilling procedure per se. And one more short thing that just I wanted to add, Kalyan, here, as before one decides to go for drilling these ovaries, one should really take into consideration, as Pratibha has already said, the patient should not have responded to the ovulations or even to gonadotropins. But there's a small star to that, those who cannot afford gonadotropins. Okay, so in that case, we must critically look at the ovarian volume and the AMH levels. I have seen best of the endoscopic surgeons who are very fond. You see a polycystic ovary during diagnostic laparoscopy, you drill, and patient comes with extremely low AMH. So it should be mandatory, in fact, that we should have a good ovarian volume and AMH of more than 5 to really consider whether this patient requires drilling, lest she lands into one. Secondly, these follicles, when you take a transverse section of the ovary and study it under microscope, these follicles are not uniformly distributed in the entire ovarian volume. There can be areas where they can be focally located, and if that point is drilled, maybe we are going to cause a tremendous decrease in the ovarian volume. So I strongly appeal everyone that do not drill unless the AMH is more than 5, and of course follow this rule of 4 and have a look at these ovaries before posting them for surgery, critically on ultrasound, to know their ovarian volume. Thank you very much.
Very well said, sir. The decision should not be made on that OT table. It has to be made in your OPD prior to doing a counseling of the patient, looking into the volume of the ovary, counseling of the reports like AMH, ovarian volume. You decide which part of the ovary you are going to drill. Dr. Megha, please.
Sir, I just have a thought. If we do stromal vascularity prior and see that if stroma is really vascular, then we'll be damaging that stroma by adding the punctures, no?
That is our aim. Our main aim is to cut down that stromal androgenicity to come into play.
But then vascularity also will come down.
Sorry?
But the vascularity also will come down.
Yeah. So our aim is to bring down the stromal androgenicity, which is the culprit in folliculosis. Higher the intra-ovarian androgenicity, poor the response, the worst quality of the oocytes will get.
But more the vascularity of the stroma, more the drugs will be reaching the ovaries, sir. So
yeah, that is true. But the patient, I'm getting you. But the patient who has, in that case, your patient would have responded to oral ovulations or gonadotropics.
Yes, ma'am. That is what the patient selection has to be very correct for surgical approach for a PCO. Otherwise, you increase the dose of gonadotrophins and they will definitely respond.
Yes. Yeah, I mean to say, if we put the color and say that there is no good vascularity in the stroma, we are safe to dream. I mean to say that.
No, but if even if the vascularity is there, see, PCO is a complex problem. Suffice it to say today that if the patient has not responded to your first line or second line of treatment, before you think of IVF, post these patients for drilling, and you may be able to save the cost of IVF in them.
Okay, thank you.
So this was a spot diagnosis which we could see Cox patient. And is it a fertility enhancing surgery? Sir, this is a laparoscopic interval cervical cerclage. So how do you rate? Nowadays, it is the recurrence. We are doing a lot of interval cerclage. So is it a fertility preserving surgery or not?
I do not have any experience of cerclage, but I have seen Dr. Kade doing cerclage on patients with a very bad obstetric history, with failed vaginal approaches for cerclage, doing laparoscopic cerclage, and he has succeeded in getting these patients a live baby. No experience of interval cerclage. Sorry.
Oh, interval cerclage is always better. The advantage, patient is not pregnant, so there are complications of surgical difficulties ruled out. Thromboembolism is ruled out. Secondly, very important is that patient is now very clear in her mind that now she's going to have an interval cerclage, which is good for an obstetrician or laparoscopic surgeon because the skill required is very low. It is the surgery which can be done by average endoscopic surgeon because you can manipulate the uterus as it is an interval cerclage and not pregnant. So there are difficulties during cerclage, during the pregnancy. So it's always better and it is proving best for the endoscopic surgeons. So here we
don't have any statistical analysis for this interval cerclage, but just to ask, get the clarification from you, Kalyan, with your experience. I fear because it's very difficult to label anybody a case of cervical incompetence dogmatically unless we really screen these patients in their non-gravity state, okay, to know whether the patient truly has cervical incompetence. Mere previous losses in the mid-trimester or deliveries, if this patient goes into labor prematurely, 100% of these patients will require laparotomy.
Yes, sir. Secondly, if your diagnosis is right, that there are previous 2 or more second trimester losses. Secondly, there is a failed cervical cerclage done in the prior pregnancy, as 95% of the gynecologists do McDonald cerclage. And Shirodkar is a big skill. Nowadays, there are no teachers to teach Shirodkar cerclage also. That is a big problem that Shirodkar cerclage is only done by 4 to 5% of the people across India. So if there is a failure of previous 2 cerclage history related second trimester losses, is always better to go for interval cerclage. I know this patient might require a hysterotomy or sometime putting a laparoscope and cutting this thread, and she can have a preterm delivery. So second surgery might be required, but there are advantages. I have done a limited study where I have done around 22 cases in last 2 years. Almost around 10 have delivered and 3 and 4 are during pregnancy and 4 have lost to follow. It has very good results if you are done in an interval cerclage because during pregnancy it's very difficult. I have seen a case done by Dr. Pandit Palaskar at 22 weeks of pregnancy, doing the McDonald as doing a cerclage, that is a rescue cerclage, and that pregnancy has gone till 34 weeks. But it takes a lot of courage to do a cerclage during the pregnancy, and that's why we prefer to do in an interval cerclage.
Just to add, we have found a via media to this laparoscopic versus McDonald's. We have been now of late started doing modified Shirodkar cerclage. Modified in the sense that we do not open the Douglas's pouch, dissect the bladder little up, and this has been done under guidance of Dr. Sardesai Madam, of course. And nowadays, all those patients with previous McDonald who have been practicing modified Shirodkar version of circulation. Maybe thanks for suggesting this. I would present that data at Nashik conference.
We need to have one session on that, Dr. Kalyan.
Yes, ma'am. We'll take one. Thank you, Dr. Sudesh, Dr. Megha, Dr. Sudeep, Dr. Supriya, Dr. Anuradha Madam, Dr. Monica, and my sincere thanks to Dr. Dabde sir for guiding us, conceptualizing this panel. I'm really thankful to you, sir. So at last, I like to thank Nikhil Patil from Sun Pharma, Sunil from Sun Pharma, and Dr. Monica Umbardhan, who has taken a lot of efforts to get all of us together. We had certain time restrictions, so we are winding up this panel now. It is almost 1 hour, 5 minutes. Next time, the remaining 3-4 cases we can discuss with some other societies. That time you can log in. Thank you so much. Over to Dr. Monica.
Thank you so much, sir. For the official vote of thanks, I would like to thank Pardeshi sir and Sujata ma'am from Amox family, Dr. Sadhna Patwardhan madam and Prakash Trivedi sir on behalf of MSR, Dr. Lakshmi Srikhande madam and Ashok Kumar sir on behalf of ICOG for allowing us to conduct this webinar under the aegis of MSR and Amox. Thank you, Kalyan sir, for the opportunity for coordination. I would also like to thank Pratibha as a master of ceremony for this webinar. All the esteemed faculties, Dabde sir, Megha ma'am, Sunita madam and Bhuyar madam, thank you for your excellent deliberations. I thank all the panelists, Sudesh Doshi sir, Pratibha, Meenal, Supriya and Sudeep for joining, and Anuradha madam for joining in. Thank you, Sun Pharma, for your academic contribution. Thank you so much, everyone. Good night.
See you soon. Thank you after 15 days with some other society. Thank you.
Sure.
Thank you, sir.